Okay, I think we can go ahead and get started, and I guess we'll just start officially the meeting at 9 with our first speaker. But I just wanted to start the meeting early. I thank you all for joining this early in the morning. I wanted to start with just paying tribute to Linda, who passed away maybe about a month ago, unexpectedly. Linda Bartola. And I just wanted to mention that she had been working, well, I've known her since I've been in the organization, maybe a little over 20 years, but apparently she's been there much longer, I guess 40 years. But she did more than just our organization. She managed 40 other specialty societies. And she originally started her career at UMD-NJ and then moved to the Academy of Medicine at the time, which was an arm of the New Jersey Medical Society. Do you remember the New Jersey Medical Society is now, I guess, our organization? Maybe it's sort of morphed. She joined the SCG, which it was at that time called the Terenson Group. I guess that's after Mike's name? Terenson?
My dad, actually, my dad.
Oh, is your dad? Okay, in the mid-90s. And that wasn't that long ago, by the way. She was a member of the New Jersey Society Association Executives and was widely recognized as one of New Jersey's top executives in the field. She grew up in Newark, just around the corner, and enjoyed spending time with her extended family, her siblings, her niece and nephews. So does anybody want to say anything about Linda? I mean, we all had some personal experience. I just remember her as the boss. She told us what to do and we did it.
Hi everyone. Good morning. It's Evan.
Hi, Evan.
Hi. So first I have to confess, I'm in my pajamas. I'm not in, my tie. I still underdressed, but you know what? This is the most comfortable I felt at our meeting. But seriously, I mean, Linda, if it wasn't for Linda, there's no way I could have accomplished what I needed to get done as president. She was sort of the glue that held our organization together behind the scenes. There's so many things logistically that she helped with, connecting us with great speakers, getting them scheduled, getting their hotels and transportation worked out. So many things behind the scenes that would have been impossible for me to do. First of all, I'm not organized enough to arrange logistics. I can barely keep my schedule going. So I learned a lot from her, and honestly, I think without her, it would have been impossible for me to be president of the NJRA. So I miss her, and she's also just a lovely, sweet person. I like talking to her about her family when we get together, and she was just sort of a rock. We just assumed she would always be there, and so like the rest of us, I'm so sad that she's no longer with us.
I agree.
No, she was. I think, Doc, that was well said. She was the taskmaster and kept us all in line. So she was great, and she will be missed.
I also want to mention that I didn't know this, but Dr. Spira, Harry Spira, passed away also about 5 weeks ago, according to an obituary. I guess someone saw an obituary. I didn't realize that he's another person that everybody knows. He's been around in New Jersey, one of the grandfathers of rheumatology in New Jersey for forever. I'm just very sad to hear that he also passed away. But I guess maybe you guys up north must know him very well. I know he trained some of you. Maybe in
he was the first associate of Charlie Plotz. I was the third, so I knew him moderately well, and I used to use him when I was in Brooklyn and even sometimes in New Jersey as a second opinion. He was very good at that. He never tried to steal your patient by any means, but he was very smart, very good.
Yeah, we co-managed a lot of patients, and yeah, he was very, very smart. Absolutely. So another person we're going to miss.
Yeah, I've known him for 50 years. I knew him in my internship. One of the first people who taught me rheumatology after I graduated from Einstein. And he had a tremendous connection with the Hasidic community because he knew Yiddish, and he was like the star of many of the Jewish communities throughout the world. I'm in Jerusalem right now, but when he came to Jerusalem, there'd be a line of people waiting to see him because of his reputation. He's one of the first people who described polymyalgia rheumatica, and he was very active in the Sjogren Foundation. And he also was involved in osteoporosis. We started discussing osteoporosis 20 years ago at one of the osteoporosis meetings in Chicago, and he got a machine. But everybody loved him, and he was just had the kind of a personality that you'd fall in love with him. And he was very bright, and he's really, his son has taken over. His son's a terrific guy and very, very bright also. I'm sure a lot of the attributes that he had have gone over to his son, Robert. But Harry is one of a kind and a tremendous, tremendous loss to the rheumatology community.
I agree.
Hey, Noel.
I remember, I didn't know Harry very well, but his son Rob helped train me at HSS, and we're still very close. And if a patient isn't willing to go and see Vivian with scleroderma, I beg them to at least see Robert Spira, who's sort of, besides vasculitis, has developed a real interest in scleroderma. But his son is a fabulous guy, really nice, really smart, great teacher. And I'm sure, even though I didn't know Harry, from everything I've heard about him, I'm sure his son will continue to carry the baton and inspire many trainees and the rest of us along the way,
Absolutely.
Noel had something to say. I think her speaker was not on. Hey, Noel.
How are you? He was just, do you hear me? I don't know.
Yes, we hear you.
How are you, Vivian? I loved him. I always spoke to him over the last 44 years. As Ralph spoke beautifully about him. And I'm friends with his son. And whenever you had a question, the two of them, they're on my cell phone all the time. Whenever I wanted to speak to them, they were great. They are, well, the son is a great person, and Harry nobody could be like Harry. He used to come over to Columbia and talk to everybody in the old days. He was a great man, great man.
David Worth. Harry
Dave.
came and spoke to our group on temporal arteritis a few years ago over at Barnabas, and it was very, very well accepted. My mentor, Peter Barlin, was very close to Harry, and I got to talk to Harry and also his son about different cases, and it's been a worthwhile experience. Some of my patients who would go into New York and then also see me, we would call him Uncle Harry, because we're very affectionately that he was such a good fellow, nice guy, and very caring.
Okay. I think maybe we can get started. I could start by introducing Dr. Richard Lesser, who is joining us from Winston, North Carolina. He trained at Wake Forest. He was the director, or is the director, of the Thurston Arthritis Research Center at UNC since 2017. He's a distinguished professor, known as the Herman and Lewis Smith Distinguished Professor, Division of Rheumatology, Allergy, Immunology at UNC since 2014 until now. He serves many roles. He's the director of basic and Translational Research, Thurston Arthritis Research Center, professor of biology, cell biology and physiology at UNC since 2014. He has a research interest in osteoarthritis and has written many chapters in the pathogenesis of osteoarthritis, as well as keeping us up to date and up to date since 2018. He has multiple NIH and other grants and conducts research, has lectured and published more than hundreds of articles in the pathogenesis and management of osteoarthritis, cartilage biology, molecular mechanism, the effect of aging and osteoarthritis on chondrocytes, as well as responsiveness of IGF, insulin growth factor inhibitor. So Dr. Lesser, thank you for joining us, and we're excited to hear you.
Okay, thank you so much for having me. I'll see if I can share my screen now. All right, is that showing up okay?
Yes.
Great, great. So yes, I'm sorry I can't be there in person, but I'm glad we can still have this meeting virtually. And I'm excited to talk about my favorite area, which is osteoarthritis. I have a few disclosures. The only thing on this list that I might mention today are senolytics that are being produced by Unity Biotech. Otherwise, these aren't relevant. So everybody, I think, understands that osteoarthritis is by far the most common form of arthritis. It affects over 30 million people in the United States. With the aging of the baby boomers and the fact that both aging and obesity are important risk factors for osteoarthritis, the prevalence is expected to double over the next 20 years. And knee pain is responsible for about 85% of the global pain and disability from OA worldwide. And that's one reason why a lot of the research that you'll hear about has been focused on knee OA. Not that hand, hip, spine is not important, but in terms of the pain and disability from OA, knee OA is responsible for a lot of it. And of course, there's been a continued rise in joint replacement surgeries. And one reason for this is that currently we don't have any treatments for osteoarthritis that actually target the disease process and slow the progression of the disease. So we have symptomatic therapies that I'll talk about, but what we really need are disease-modifying drugs. And I'll try to update you on where we are in the search for disease modification agents. Oops. So what I'd like to cover in today's talk, first I'm going to review the pathogenesis of osteoarthritis, and I have the itis emphasized there because, as I'll try to demonstrate, this really is an inflammatory form of arthritis. It's just a different type of inflammation that you might see with, say, rheumatoid arthritis. It's not just simply cartilage wear and tear. That's what people used to think about. But there are really a bunch of inflammatory mediators and matrix degrading enzymes that are involved in OA that are potential targets for therapy. We'll review the current OA management. I'll talk about the ACR guidelines that came out earlier this year. Non-pharmacologic interventions are currently still the best treatment for OA, but new targets are coming based on the biology. And in terms of looking for disease modification, MR is replacing radiographs, at least for research studies and clinical trials in osteoarthritis because of the sensitivity of MR, and I'll talk a little bit about that. And then finally, I'll talk about the challenges we have in moving the field forward and the need specifically for phenotyping or subtyping osteoarthritis patients. It's a very heterogeneous condition. Currently, we treat everybody the same, whether or not they've had OA in their knee from a joint injury like an ACL tear versus obesity-related OA versus aging-related OA. They tend to all get lumped together. It might be for future therapy, we're going to have to target specific subtypes of OA. So I'll cover that as well. So as I mentioned, historically, osteoarthritis was thought of this sort of wear and tear disease. It was often called degenerative joint disease or DJD. And this is a quote from a review in 1955 in JAMA that it's basically a wearing away of cartilage with reactive proliferation of bone, where you get the osteophytes, as you can see here, and thickening of the capsule. But this makes it sound like osteoarthritis is like an inert object, like an automobile tire that just wears out over use. And we know that our joints are composed of living tissues. So it can't be just simple wear and tear. There's a biological process behind this. And understanding the biology will be important as we try to develop new treatments. So there are a number of different factors, risk factors for osteoarthritis, systemic factors, aging, genetics is important, gender, obesity, and a number of different biomechanical factors. Malalignment, which is particularly important in knee OA, and we'll talk a little bit about that. Joint shape, particularly for hip OA. Obesity is both a mechanical factor by increasing the load on the joint, but also a systemic factor because of the inflammation associated with obesity. And of course, joint injury. And I show you changes here at the bottom of articular cartilage, nice, normal, smooth cartilage with normal underlying bone. In an osteoarthritic cartilage, you can see loss of matrix resulting in this loss of staining and these clefts and fibrillations, thickening of the bone. This little piece here that's pushed into the bone would look like a cyst if you had a radiograph of this joint. So these are classic changes in cartilage and bone. But it's important to also keep in mind, osteoarthritis involves all the tissues within the joint. So it's really a condition of the joint as an organ. So in the knee joint, there's meniscal damage that parallels the cartilage damage. Tears of ligaments are very common. Often these are degenerative type tears. So in older adults on MR, 80% or so will have evidence for a tear when they never had a symptomatic traumatic tear. So it's more of a degenerative process. And then synovitis seems to play a role in osteoarthritis as well. And we'll talk about this in a little bit more detail. And because of all of these different tissues that are involved, there's a production of a number of different cytokines, chemokines, growth factors, matrix metalloproteinases, which are the MMPs, that are all involved in this process, coming not just from the cartilage, but also from the other tissues as well. So this is all sort of becoming a much more complex biological process than we thought about in the distant past. So if you look at MRI of a knee joint affected by osteoarthritis, you can appreciate this synovitis up here in the peripatellar region is pretty striking. And the other thing that is being appreciated are these bone marrow lesions. So here's a bone marrow lesion here, and these are commonly present in osteoarthritis as well. In terms of the synovitis, these are pathological specimens taken at the time of joint replacement surgery. You can see everything from normal looking synovium all the way to this grade 3 synovium here, which is severe synovitis. If you didn't know better, you might think that this tissue came from someone with rheumatoid arthritis, and this was pannus. So there's variable degrees of synovitis in people with osteoarthritis. One of the big differences between the synovitis and osteoarthritis and rheumatoid arthritis or other forms of inflammatory arthritis are the cells that are present in the synovium. So this is a study where they looked at the various cell types in OA synovium over here and RA synovium over here. And the biggest difference that you can appreciate are all of these red cells that are marked here, colored red, are macrophages. So the osteoarthritic synovium has a predominance of macrophages and then fewer T cells and dendritic cells. Whereas synovium in rheumatoid arthritis and other forms of inflammatory arthritis, it has macrophages, but T cells really predominate. So the synovitis and the inflammation in the OA joint is much more activation of the innate immune response as opposed to the adaptive immune response that seems to be predominant in, say, rheumatoid arthritis. But clearly both are inflammatory forms of arthritis if you look at this. There are a number of inflammatory mediators that are present in synovial fluid in OA. And this is a study where they did ELISA assays of OA synovial fluid as well as serum. And I just wanted to point out something. In blue are interleukin-1 and TNF. If you look at the levels of these in OA synovial fluid, they're present in very low levels. This is 1 picogram per mil of IL-1 and 2 to 3 picograms per mil of TNF. But these cytokines have so far received the most attention, not just in RA, but also in OA. But if you look at other cytokines, interleukin-6, VEGF, MCP1, IP10, and MIG, these other cytokines are present at much, much higher levels. And they might be more important in the osteoarthritis process, and I think deserve more attention than they've been given so far. Is there evidence for this? Well, there has been a clinical trial of a drug that was developed by AbbVie, which is a dual anti-IL-1 beta inhibitor. And this was tested in knee-OA, and they recruited people with synovitis thinking they'd have more inflammatory OA. Well, inhibition of IL-1 alpha and beta had no benefit at all for WOMAC pain and no change at all in MR synovitis. And then a second study was done with the same inhibitor, looking at erosive hand OA, because erosive hand OA is thought to be a more inflammatory form of OA, and maybe that is where IL-1 plays an important role. No improvement in pain, no improvement in the injury imaging outcomes. And then there's also been several trials of anti-TNF for OA. I'll just show one of them, an etanercept trial for inflammatory hand OA again, no improvement in pain and limited improvement in imaging outcomes. So a number of clinical trials, inhibition of IL-1, TNF, so far in OA have failed. And I think that these are probably not the right targets, and perhaps some of those other cytokines are going to be more important. So I mentioned the bone marrow lesions, and again, here's an example of a bone marrow lesion, subchondral bone just underneath the cartilage. These bone marrow lesions are associated with mechanical factors. So having a medial lesion, as shown here, is associated with having a varus alignment. The varus alignment, or bow-legged, puts more force across the medial side of the joint. Lateral bone marrow lesions are associated with valgus alignment, or knock knees, because there's more force across the lateral side of the joint. So these bone marrow lesions seem to be at least in part mechanically driven, but it's also important to know that they're associated with progression. So if you have a medial lesion, your odds of medial progression go up, and same for lateral lesions, lateral progression. And they're also associated with pain. And histologically, these bone marrow lesions are areas of microdamage. So they contain fragments of bone, microfractures, some necrosis and fibrosis, and abnormal adipocytes. So it's thought that these lesions are probably mechanically driven, but contribute to the OA process through damage to bone, and also because this seems to be a source of pain in OA. So that's just an example of how bone is important in osteoarthritis. Now, I'm not going to go through this whole slide, but again, the emphasis here is just to show you that there is a complex biological process behind osteoarthritis. The synovium produces a number of inflammatory mediators that are shown in this box. The bone produces mediators that can affect the overlying cartilage. TGF-beta and bone morphogenic protein 2 are seen to be the growth factors that stimulate osteophyte formation. And these are produced by the synovium as well as by the cartilage. And then just shows you a chondrocyte. There are a number of different mediators that have been shown to activate chondrocytes to produce matrix degrading enzymes. Wnt signaling that we'll talk about because that's being targeted therapeutically, but even the complement pathway has been shown, at least in some preclinical studies, to be involved in OA, toll-like receptor signaling, and so on. So again, the point here is OA is a complex biological process. We're learning about all of these different factors. What we really need to do for disease modification is to find out what are going to be the best targets. And at the level of the chondrocyte, I've been studying OA for 30 years now, and it's fascinating how many different inflammatory cytokines shown over here have been shown to be present in OA tissues. And these inflammatory cytokines stimulate matrix degradation and inhibit synthesis. On the other side here, there are a number of different growth factors also present in joint tissues that stimulate synthesis and inhibit degradation. What happens in OA, there's an imbalance between these two sides. So you have excessive degradation relative to synthesis. This drives production of matrix metalloproteinases, aggreganases, other proteases that degrade the tissue. Cells within cartilage can become hypertrophic, which is similar to the growth plate, where they make type 10 collagen and MMP13, which is a collagenase. And then there's the activation of a number of different signaling pathways, Wnt, Notch, Indian hedgehog, and so on, that are involved in this. So again, lots of potential targets in this process, and a complex biology that involves a number of mediators in OA. So I've mentioned aging and obesity as being two of the important risk factors for OA, and this just shows some data. This is from Elena Lucena, and this is the prevalence of diagnosed symptomatic knee OA. And you can see with increasing age, the prevalence goes up. And then you can see how obesity affects the prevalence, highest in females, followed by males. And then here's the non-obese females and males. So you can see how these two risk factors are interacting with each other. The other thing to notice on this graph is somewhere after the age of 50 to 55, there's really a jump in the prevalence of osteoarthritis. So there are aging-related changes that are playing a role in this that seem to be coming into play at around that age. So what are some of these aging-related changes? First, I just want to emphasize that aging and osteoarthritis are not one and the same thing. So these are femoral condyles from tissue donors. And you can see this was a young, normal, healthy donor, male in his 30s, normal appearing femoral condyles. And this is histological cartilage section from the same joint. You can see this nice, thick cartilage and thin subchondral bone. This is an older adult in his 60s. You can see some browning of the tissue. So there's some advanced glycation end products that accumulate in cartilage with aging. And with normal aging, you see thinning of the cartilage histologically, but it's different than what you see in osteoarthritis. So here's the OA joint. This is an osteophyte out here. You may not see it, but there's cartilage loss in these regions. And histologically, you can see damage to the cartilage surface, loss of staining, and the thickening of the subchondral bone. And as I mentioned, other tissues are involved as well. So people used to think about OA just being sort of an age-related condition, but the aging changes are different than what you see in OA. Aging changes may predispose to OA, but it's not one and the same process. So cell senescence is something that's important in osteoarthritis, and this is some data from our own group looking at a marker for cell senescence, and this marker is called P16-INK4A. So this is probably the best biomarker right now that we have for senescent cells. And you can see measuring P16 expression in human chondrocytes of different ages, how P16 levels go up with age. So this is just a sign that chondrocytes are becoming senescent with age. And senescence is important because it could play a really critical role in the development of OA. There's replicative senescence that occurs when cells multiply multiple times. That's probably not important in osteoarthritis because, at least in cartilage, chondrocytes very rarely divide. But there's another form of senescence that's probably more important, and this is called stress-induced senescence. And so this occurs in response to excess mechanical loads, which you know are important in osteoarthritis because biomechanics play an important role. And then also some aging changes, oxidative stress, mitochondrial dysfunction, they can also contribute to stress-induced senescence. And as you see, there's a number of different transcription factors and a number of changes that occur in the cell. But what's really important, I think, to emphasize in terms of OA is that senescent cells assume a special phenotype. And this is called the senescence-associated secretory phenotype. And this senescent phenotype is characterized by the production of these inflammatory mediators, cytokines, chemokines, MMPs, and certain growth factors and growth factor binding proteins. And the inflammatory mediators and the matrix degrading enzymes that you see in this box, these have been shown to be produced by senescent cells. And if you'll remember what I showed you a few minutes ago, these are same mediators that seem to be important in osteoarthritis that are found in osteoarthritic joints. So there seems to be a connection between this senescence-associated secretory phenotype and osteoarthritis. And so drugs are being developed that will kill senescent cells specifically, and these are called senolytics. And in preclinical studies, senolytics have been shown recently to be of benefit for osteoarthritis. So this is a study published by Jennifer Alicieff, who's at Hopkins. And this is using a senolytic from a company called Unity, this UBX compound. And this was in mice in a surgically induced osteoarthritis model. And the ORSI grade is a grade for cartilage damage. And if you just look at the triangles over here, this is the vehicle control mice, and these are the mice treated with the senolytic. You can see significant improvement in the cartilage damage in the mice that were treated with the senolytic. And then they also looked at age-related OA using a different technique to remove senescent cells. And again, these are the mice that had senescent cells removed compared to the control mice, and much less cartilage damage. So there have been a couple of other studies with similar results, that in preclinical models, killing senescent cells is a benefit. And what's interesting is this is not just age-related OA. This surgical model was more like post-traumatic OA. So there seems to be a role of senescent cells after trauma. And so phase 1 studies are ongoing using injections of senolytics into joints to see if they might be of benefit for knee OA. So if you look at the predisposing factors for osteoarthritis that I've been talking about already, you look at end-stage disease. End-stage disease looks the same no matter which factors a particular individual might have leading to the OA. But I think what we're starting to understand is that the pathways by which these factors lead to osteoarthritis may be very different. And that's important in terms of when we start thinking about targets for therapy, that if there's a difference among a pathway, so something you develop for, say, age-related OA may or may not work for obesity-related OA, and so on. So this is something important to keep in mind as this talk goes on. So some evidence for that. This is another preclinical study that we did in mice using a knockout of a cytokine called macrophage migration inhibitory factor, or MIF. And this cytokine has been associated with aging. It's also been studied in rheumatoid arthritis and in lupus as well. What we did was we looked at mice that had MIF knockout, and we did a study looking at mice of different ages. So after about 12 months of age, mice start to develop changes of OA. So this is a cartilage structure score. And you can see here's the control mice, and here's the MIF knockout mice. Significantly less OA in the MIF knockout mice at both 12 months of age as well as 22 months of age. And then this is osteophyte score, another classic feature of OA. Fewer osteophytes, at least at 12 months, not significant at 22 months. So age-related OA was less in mice that had the MIF knockout. But we also took these mice at a younger age, and we induced OA in an injury model. And the MIF knockouts were not protected in the injury model. So this is another score for cartilage damage. These are the wild type mice that received the surgery, didn't receive the surgery. These are the MIF knockouts that received the surgery, didn't receive the surgery. No difference between the two groups. Same with osteophytes. So this shows you that with this particular cytokine, knocking it out prevented age-related OA, but not injury-induced OA, so showing that there could be two different pathways in this particular case. So genetics play an important role in osteoarthritis. About 40% or so of the risk of OA is genetic, and most likely polygenetic and environment and genetic interactions. This is a recent study published last year in Nature Genetics using the UK Biobank, which is an amazing source of samples characterized for a number of different diseases, including OA. So they had over 77,000 cases of knee hip or knee plus hip OA and over 300,000 controls. And they found 64 risk loci, 52 of which were novel, for osteoarthritis. And they examined these risk loci in different ways, but one thing that they pointed out that I think is important is that four of the risk loci are already considered potential targets in osteoarthritis. This is TGF-beta, GDF5, which is a growth factor, FGF18, which is another growth factor, and this enzyme cathepsin K. So when there's genetic evidence for a factor being involved in OA, that increases the chance that a therapeutic might work. And so I think developing these particular therapeutics has promise based at least on the genetic evidence. So I'll talk about a couple of these in clinical trials. So now we're going to turn to treatment of osteoarthritis, now that you've got the background on the biology of the disease. So for every type of arthritis, including OA, our treatment goals are obviously to relieve pain, because that's why our patients come to see us. We want to reduce inflammation when inflammation is present, because we know this plays an important role in disease progression. We want to improve function, because arthritis obviously interferes with function. And then what we'd really like to do is halt progression. We're being able to do that now in rheumatoid arthritis, psoriatic, ankylosing spondylitis, and so forth. We're not yet there in osteoarthritis, but I think we're getting closer. So one of the important things, though, about osteoarthritis is that a lot of times when our patients come to see us, they're seeing us with more advanced osteoarthritis. Here's an advanced knee radiograph where you can see this side of the joint is almost completely gone and bone on bone. So often the disease is advanced, and an intervention at this stage is not going to slow disease progression. It's too late. Joint tissues don't repair themselves very well at all. And so if we're going to affect disease progression, we're going to have to be able to treat patients at an earlier stage. So the idea is the intervention would start when there's much less damage. And to be able to do this, we're going to need to have better risk biomarkers. So whether these are biochemical markers, imaging markers, or something measured mechanically, we're going to need to be able to detect OA at earlier stages and then pick the right people to intervene with a disease-modifying drug. So to talk a little bit about what we have available now, I just want to briefly review the ACR guidelines that were published earlier this year. We were fortunate to have several people that are underlined from UNC that were on the guidelines committee. And they made these guidelines very practical for clinicians to use. So I'm going to go through a few things, but basically I'm going to show you figures where they have strong recommendations for use. And this is where the evidence for efficacy and benefits clearly outweigh any harms or burdens. And then they had recommendations for clinical recommendation for use where the quality of evidence is not as high or the balance of benefits is more close to harms. And then they have interventions that they recommend against using. So we'll go through these because I think clinicians are definitely interested in this. But to get the details about how this was developed, I'll refer you to this paper that was published in Arthritis and Rheumatology. So first, they divided these into, the first group is physical, psychosocial, and mind-body approaches. And you can see in the darker green is strongly recommended and the lighter green is conditionally recommended. And they divided these hand, knee, and hip OA. So exercise is clearly important for osteoarthritis. Self-management programs have been shown to be helpful. Weight loss for knee and hip. In some people, Tai Chi, use of cane, knee braces, first CMC orthosis for hand OA. So these were the strongly recommended interventions. And then you can see a number of other interventions that were conditionally recommended. They may have some benefit and certainly don't seem to have much in the way of harm, but don't have as much evidence for efficacy as the others. Then they looked at the pharmacological approaches. And again, we have strongly and conditionally recommended. Oral NSAIDs are still recommended. And of course, this is the pharmacologic therapy that's most commonly used for osteoarthritis because of their benefits as an analgesic. For knee OA, topical NSAIDs can be of use, particularly in patients where you want to avoid side effects from oral NSAIDs. And then they still are recommending intra-articular steroids for knee OA, and if guided injection is possible for hip OA. And then the other types of analgesics and things like duloxetine are conditionally recommended for OA. All of these for all forms, and then topical capsaicins for knee. So these are the pharmacological approaches. Then I think it's important to look at what they recommended not using at this time. So strongly against TENS, and then conditionally against a number of other interventions, in large part because lack of evidence for efficacy. And for some of these, you'd think, well, massage therapy is not going to be harmful. But I think it was more a lack of efficacy that they ended up on the conditionally against list. And then in terms of pharmacologic approaches, a whole bunch that are currently on the strongly against list. So a number of these have been tested already in clinical trials and found not to be of benefit. So bisphosphonates, glucosamine, hydroxychloroquine, methotrexate, TNF inhibitors, IL-1 inhibition, and so on. Platelet-rich plasma, which I know a lot of clinics are using, stem cell injections, chondroitin, and so on. Strongly against because of lack of evidence for efficacy and potential harm from a lot of these. And then a number of others that are conditionally recommended against that are listed down here. So I mentioned exercise and diet, and just to show you, because this is currently our most effective treatment for knee OA, this is one particular trial that I was involved in called the IDEA trial, which was a combination of walking and diet to reduce weight by greater than 10%. And this was an 18-month trial. And then the combination of diet and exercise. And this was published in JAMA a number of years ago, but you can see that the diet plus exercise group had significant reduction in pain. This is the WOMAC pain score, which is commonly used for knee OA trials, 51%. So this is a reduction in pain that you don't get with any other intervention that's currently available other than joint replacement surgery for OA. And at the end of the trial, you can see 38% of the participants in the diet and exercise group reported little or no pain when they started with significant pain. So just to emphasize, these non-pharmacologic approaches are still useful. We just need to be able to motivate patients and get them to participate. So I want to spend the rest of the time talking about disease-modifying drugs and where we are with those. So there are a number of different categories of disease-modifying drugs that are listed here. So I mentioned that matrix-degrading enzymes are important in OA, and inhibitors of MMPs have been developed, and aggrekinase as well. Bone anti-resorptives, I've mentioned bisphosphonates already, that so far have failed, so I'll talk about some of those. Anabolic factors, particularly FGF18, that we'll talk about. Anti-cytokines, anti-inflammatories, cell signaling inhibitors, and then the senolytics. So these are all the major categories that are being studied right now for disease modification in OA. So first, this is one of the failed bisphosphonate trials. This was the COSTAR study. Over 2,000 subjects were in this 2-year study, And they did this because there was preclinical evidence that bisphosphonates might be of benefit for OA, and because of these bone changes in OA I've talked about. But in this particular trial of risedronate over 2 years, no improvement whatsoever in pain. This is the WOMAC pain score, compared to the placebo. And the only outcome that showed any benefit was a decrease in this biomarker CTX2, which was thought to be a marker for cartilage breakdown. But CTX2 is also produced in bone. And so it's the effect of the bisphosphonate on bone resorption that caused the biomarker CTX2 to go down. No change in joint space width. And at that period of time, measuring joint space width was what the FDA required if you wanted to register a drug as disease modifying. And this is a huge challenge, showing that you can slow the loss of joint space over a 2-year period. And so I'll talk a little bit about that and then talk to you where the field is going from there. So in this particular COSTAR study, these are the people in the placebo arm. And you can see in the placebo arm how very few people over the course of 24 months had a decline in joint space width. So 71% in the placebo group, their joint space width stayed the same over 24 months. And then there were 2 groups that had a minimal decline and a moderate decline. The group that with the greatest decline of 2.1 millimeters in joint space width, that was only 2% of the people in the trial. So if your placebo group is not changing and you're trying to have a drug to slow disease progression, you're not going to be able to see this using joint space width as your outcome measure when this is the rate of progression by joint space width. And the people that were more likely to progress, as you can see, they had lower joint space width at baseline. They were also older and heavier, but just selecting out those people would still be very difficult for a clinical trial. Just to bring home the insensitivity of plain radiographs relative to what's being used now, which is MR. These are pictures from Ali Gurmazi, who specializes in this area. These are radiographs and MR images from the same person 24 months apart. If you look at the radiographs, these really look pretty much the same over 24 months in terms of the joint space and the other findings. But if you look at the MR over 24 months, here's a region where there's been significant cartilage loss. So joint space width on a plain film is just not sensitive enough to detect this. And so that's been the big issue in OA clinical trials. So the FDA just recently has put forward a proposal for approval of a drug for disease-modifying activity in OA, where they could give a conditional approval after a 1 to 2 year trial based on some different outcome measures. So patient-reported outcome, such as pain, needs to be met. And then a surrogate marker. So this could be a MR image marker, like cartilage loss, or a biochemical marker. And then for the longer term study, we'll talk about in a second, an observational outcome is also included. So what they're saying is that if you have a clinical trial of a disease-modifying drug and within 1 to 2 years, you show that a patient-reported outcomes improved and a surrogate, you can get a conditional approval, and which is really important to companies. But then they have to continue the trial for another 3 to 5 years and show continued improvement in the patient-reported outcome, plus either a surrogate marker or another observational outcome. So with this in mind, I think this is bringing more pharmaceutical companies back into the OA space because they feel like they can do a clinical trial and get conditional approval and continue it much easier than what was possible before with just looking at joint space width. So a few of these trials that have been recently reported. This was a trial of FGF18, sprifurmin, published last year in JAMA. And this is a growth factor that was thought to stimulate cartilage production. They had 5 groups, 549 participants, receiving different doses of sprifurmin. And this was over a 1-year period of treatment, and then they followed them out for 2 years. The primary outcome was change in femoral joint cartilage thickness, measured at 2 years. And the particular 100 micrograms of FGF18 given either every 6 or 12 months did result in significant improvement in cartilage thickness compared to the placebo. So there was definitely improvement in the cartilage. Unfortunately, there was no improvement in pain. So WOMAC pain, total pain, function, stiffness were not improved. So this is a case of a trial where the cartilage was thicker, but there was no symptomatic improvement. But they're continuing to do a longer term study to see if maybe over time the pain will come after the structure has improved. If there was an ACR update actually last year where they saw a subgroup where there was some improvement in pain. Another recently published study of a cathepsin K inhibitor. Cathepsin K is an enzyme that's active both in bone and in cartilage. So this particular cathepsin K inhibitor in a phase 2A study, there was no improvement whatsoever in symptoms. So again, this is change in pain, but they did see improvement in some of the radiographic outcomes. So one of the key outcome measures was femoral bone area, which when that goes up, that's a sign of progression of OA. That went up more in the placebo group than the cathepsin K inhibitor. And then cartilage thickness went down more in the placebo group. And then some biomarkers also responded to cathepsin K. So again, this is a second potential disease-modifying drug where there was improvement in structure, but not improvement in symptoms. And so it's disappointing because you would hope that both would improve together. But again, they're going to try to do longer term studies to see if maybe the symptomatic improvement is going to come later. I mentioned Wnt signaling as being important in osteoarthritis. So there are a number of different targets within the Wnt pathway. So this is just a diagram of a Wnt ligand binding to Wnt receptor, activating signaling components that increase transcription. And these are genes that are involved not only in development, which is where the Wnt pathway is important, but in osteoarthritis, certain genes like MMPs are regulated through the Wnt pathway. So there are a number of targets shown here. In this particular preclinical study from a group at Vanderbilt, they found that at least in mouse models, Wnt inhibition reduced cartilage damage, which is shown here. And so there's a company, Samumed, that's developing Wnt inhibitors and have done several different phase 1 studies of Wnt inhibitors, showing some modest improvement. This is another responder index that improved with this particular dose of a Wnt inhibitor. This is one of several phase 1, phase 2 studies that have shown some promise, and so they're entering phase 3 trials now. And so this was something to pay attention to, because unlike the other agents that I showed, here they are getting a response in terms of a symptomatic response. The last thing I want to talk about, which is not a disease-modifying drug, but is important to understand because it's up for FDA approval right now, and that's tanezumab. And tanezumab is an anti-NGF, anti-nerve growth factor. Nerve growth factor is important in pain, in osteoarthritis, as well as a number of other painful conditions. This is one of the earliest trials published in 2010, showing the benefit of, at this point, it was an IV infusion of tanezumab. And you can see a dose response compared to placebo. And this is changed from baseline over a 16-week study. One of the problems, though, that was seen in these early anti-NGF trials was a subgroup of people that received anti-NGF that had more rapid progression of their osteoarthritis. And this caused the FDA to discontinue the trials. And when they looked at all the data, They found that people in the trials that were receiving NSAIDs and also got anti-NGF were more likely to have this rapidly progressive OA. So they let the trials restart again with exclusion of NSAID use. Couple of other trials, a different anti-NGF from a different company shown here. Again, improvement of pain compared to placebo. But again, this one also had people on NSAIDs, and they had 21% in this particular anti-NGF trial that had rapid progression of their OA. And then a third trial from Tom Snitzer. This was published in JAMA just last year, end of last year. Again, tanezumab showing some benefit, 2 different doses sub-Q compared to placebo, rather modest benefit in this particular trial. And again, they saw some increase in the need for total joint replacement in the tanezumab group compared to the placebo group. So anti-NGF appears to have some efficacy in terms of pain, but there's going to be a subgroup of people that might be at higher risk of having progression of their OA. And so a lot of discussion and a lot of consideration is being given to whether or not this is going to be approved by the FDA and how safe it's going to be to use and how you're going to pick out the right patients to treat with anti-NGF. So I think this is an area to pay close attention to. So I'm just going to conclude with a few comments about how we might move forward with disease modification in OA. You know, as I mentioned at the very start, we may need to target specific phenotypes or subtypes. I don't think simply basing this on risk factors is going to be sufficient enough, or just looking at what's happening in the tissue. We've already seen, even with bisphosphonates with bone remodeling, they don't seem to be of benefit, and targeting just people with bone lesions hasn't been shown to be helpful. It's probably going to require more sophisticated phenotyping using a computational approach to find specific subgroups. We still need better imaging and biochemical markers, but they're coming along. And we need better preclinical animal models. So many things have looked good in preclinical models that have failed in human trials. And one reason is because of the age of the animals used in these trials. They often use very, very young animals and try to translate this to an adult human. And this last slide is just an example from Amanda Nelson, our group, using a machine learning approach to look at phenotypes of progression in OA. And basically, to drill down to the important part of this, looking at MR variables, demographic variables, and biochemical markers, the best way to pick out progressors was in the MRI measures, which are shown in these 2 categories. The higher the Z-score, the better the production. So MRI measures seem to be the best so far for looking at progression. Both bone marrow lesions, osteophytes, meniscal extrusion, and then one biomarker seemed to also contribute, the urine CTX2. So conclusion, osteoarthritis is a clearly heterogeneous, multifactorial condition with multiple phenotypes. There are a lot of pro-inflammatory mediators, matrix-degrading enzymes that are driving this. We need to do a better job at identifying progression. And there are a number of ongoing clinical trials, Wnt inhibitors, FGF18, senolytics, and so on, that we need to pay attention to, because I think we are closer to disease modification, and hopefully we'll have something in that category in the next few years. So I'd like to recognize my lab group that's worked with me for years now, and our various funding sources. And with that, I'll be happy to leave it here and take some questions.
Thank you so much, Dr. Lesser. That was excellent. A lot of these markers that you mentioned sound very similar to some of the markers that we look at in scleroderma.
Yeah.
But anyway, there are some questions that I'm going to read up, and maybe you can answer them. One of them is, What is the thought of the study showing increased progression of OA with knee corticosteroid injections?
Right, so that was a JAMA trial published by Tim McAlinden. You have to look really carefully at the amount of cartilage loss. It was really pretty minimal. And so there was some cartilage loss in the intra-articular steroid group, but you know, it was probably not enough to say this is serious, and that probably just needs to be replicated as well in another study. The important finding, I think, in that trial was really efficacy of the intra-articular steroid injections in terms of pain was not any better than the placebo injections. So, you know, we still use intra-articular steroids because it seems to help some patients, and also we don't have anything better in terms of sort of an acute flare of OA. You know, it's been thought if you do too frequent injections that maybe you could cause some harm to the joint. So we're always, you know, trying to keep that in mind, you know, no more than 3 to 4 in a year or whatever. But I think that the cartilage loss in that trial got a little bit overblown. I mean, I don't mean to minimize it too much, but it was not a lot of cartilage loss. And so I think that's why steroids were still on the list of recommended agents from the ACR.
Thank you. Another question. Did the changes with tanuzumab and NSAIDs resemble Charcot joints?
Good question. You know, it's not clear if this is related to a reduction in pain and people are overusing their joint, or if there's some biological interaction between NSAIDs and blocking NGF that might cause this more rapid progression. So, you know, the Charcot joint classically, you know, that's because you have a loss in proprioception and nociception, more importantly. But that doesn't seem to be occurring in the anti-NGF trials. So it's probably more on the biological side where you see this effect. But that's definitely a thought.
Thank you. Actually, this is a 4-part question. How does obesity-related inflammation, adipokines, relate to OA symptoms and disease progression? That's one question. Second question, what is the relationship between central pain processing and OA pain, which is something we see all the time? Is Cymbalta effective or others due to central processing pain? What are your thoughts on that?
Okay, so first question, obesity. Yes, clearly it's not just loading your joints because obesity is associated with hand OA. And fat has inflammation. There are macrophages in obese fat that produce cytokines, IL-6, for example, and adipokines that, at least in preclinical models in mice, have been shown to promote the development of OA. So it's thought that it's probably multiple mediators that are produced by obese tissue that are contributing in some way to OA. And in one of our weight loss studies, we measured interleukin-6, and you could see with weight loss, a drop in interleukin-6 that correlated very strongly with the loss in fat mass. So that's in part the role of obesity. The next question was about pain, and I think central pain being involved in OA. Clearly there is central pain in OA, and there seems to be important work from Tahina Ngozi at BU, where there's different pain phenotypes. And so there are some people with OA where their pain phenotype is more central than peripheral pain, and other people that have more of a peripheral phenotype. And so centrally acting agents, you know, like duloxetine, for example, may just work in a subgroup of people with OA, whereas targeting peripheral pain may be important in other subgroups of people with OA. So that's, I think, an important area as well, is pain phenotyping. If you look at the ACR guidelines, duloxetine was conditionally recommended because overall the efficacy in most people is not as great. But like I said, it could be a subgroup that responds to it well.
Thank you. What are your recommendations regarding intra-articular hyaluronic acid?
Right. So that's been probably one of the most controversial aspects to the ACR recommendations, because if you look at them carefully, Hyaluronic acid was no longer recommended. Other groups still recommend it. You know, if you look at the clinical trials, all of them together, and you do meta-analysis, some people that do meta-analysis show a little modest benefit of HA, and other people show no benefit at all. And you think meta-analysis, shouldn't you get the same answer? It's interesting. There's like believers and non-believers. So if you have a person doing the meta-analysis who thinks HA doesn't work, it shows it doesn't work. If you have somebody doing it that believes it does work, you see that it does work, but all very modest effects. And the fact that it's not a consistent finding, I think, also tells you that if HA had a really major effect, you would see it more consistently. And a lot of the clinical trials that were not sponsored by drug companies showed no benefit at all. So I think it's still being used clinically, again, because we don't have great treatments for OA, right? So people want to try what they can. Some patients do seem to respond. Whether or not that's a placebo response is hard to say, but I think until we have something better, it's still going to get used clinically, but at least in the ACR recommendations, it wasn't being recommended.
Thank you. Another question, is there a possibility that Wnt inhibitors will increase the risk of osteopenia or osteoporosis?
Great question, because clearly the Wnt pathway, sclerostin, is important in bone. The Wnt inhibitor that they're developing right now is an intra-articular injection, and it's thought that it's going to stay more locally within the joint, and you can't measure much of it systemically. It doesn't mean that it may not get down to maybe some of the bone just underneath the cartilage, but it's not felt like it's going to have a significant effect on bone, but that's certainly being looked at. But I think that's why it's not being given systemically in case there are targets, in other tissues that might be in fact affected.
Okay, thank you. What are your thoughts about chondroitin, the use of chondroitin?
It doesn't seem to be of any benefit. I think it was conditionally recommended in the ACR guidelines for hand OA, because like a study that showed in Europe,
that is actually
some hand OA improvement, but other trials, like the large trial in the US, the GATE study of glucosamine and chondroitin sulfate alone or together showed no benefit at all. Most chondroitin studies have shown no benefit. And there's no biological reason why glucosamine or chondroitin would have any effect at all. They get degraded in the stomach. They're not getting to the joint to do anything. So I think they have a nice placebo effect. So if you want a good placebo, sure, that would be all right.
Okay, another question. How we talked a little bit about intra-articular steroids having some effect on cartilage. How often do you think they can be given realistically in a patient with worsening pain?
Right. So, I think people are still following the old recommendations of no more than 3 injections a year, no more than, every 6 weeks. There have not been clinical trials to try to determine how many injections are safe. This one particular study from Tim McAlinden, as I mentioned, there was some minor loss of cartilage, but it wasn't like those people went on to develop more severe OA radiographically. So if you looked at their x-rays, you couldn't tell any difference. So, I think we don't need to overuse steroids for sure. And when we have other better treatments for osteoarthritis, I don't think we will be using them. So, I think we have to all sort of weigh the risk and benefits for each individual patient when we're considering what to use. But again, I think pointing to the fact that overall, at least in the JAMA study from McAlinden, there wasn't as much benefit as we expect with steroids in that trial. Maybe there are other things that you might want to try instead of a steroid if your particular patient is concerned about the potential side effects. A long-winded answer to say, yeah.
Okay, here's another question. How much does CPPD or other crystals that may be present with OA contribute in some way to OA?
So did Ann Rosenthal ask that question? Because
She's coming up next, but we'll ask you that first.
She is speaking on that at 11, yes. So I did not mention crystals or CPPD. I thought Ann will probably be covering that. There does seem to be a role in some people with OA where crystals are important. It's not everybody with OA, of course, but certainly there's lots of evidence that CPD crystals contribute to pseudo-gout and Milwaukee shoulder and all the other things, we've learned about over the years. And, I would say a subtype of OA, they're probably important, but not in, everybody with OA. It doesn't seem like crystals are that clearly important. Okay. But let Ann answer that.
Another question. What are your thoughts about using orthotics, bracing, things like that for therapy?
So, I think it depends on the orthotic and it depends on the mechanics of the particular patient. The simple orthotics, that people buy over the counter don't seem to be of any harm and don't seem to be of too much benefit. Some of these, there were these wedges that were tried for medial joint OA in people with varus deformities that in some people caused more pain, and so they sort of fell off. There are these flexible shoes that seem to be of benefit in some people. There was a very recent JAMA study published by another group. David Felsen was one of the, I think he was second author, just published within the last few weeks, that showed a different type of a shoe insert had some modest benefit. And so I think, it may be that in some people, some are of benefit, but which one's the best right now is not entirely clear. But at least the most recent study with a particular orthotic was of some benefit.
I guess some of that will depend on whether it's hip or knee or
foot. Most of these trials have been for knee OA, right? For hip OA, leg length discrepancies. I mean, there's certainly, those types of things where, orthotics are definitely of benefit. But yeah, knee OA is where most of the clinical trials have been done.
Okay, I think we'll wrap it up here. Thank you so much, Dr. Lesser, for your very interesting, this is the first time I'm hearing about, other than for, what we hear about in my disease, all these different cytokines. It's amazing how much can happen over time. So thank you so much for the lecture.
You're welcome.
And
thanks for having me.
Take care.
All right, thanks. I'll stay around.
Okay. Next is Dr. Maynard. I think she's on. Dr. Maynard, are you here? Hi, Dr. Maynard. Okay, I'm going to introduce you. So, hello, how are you?
Hi, how are you doing?
Okay. Dr. Maynard, she actually graduated from Rutgers. So she's a New Jersey, homegrown New Jersey graduate. She did a residency in New York at Mount Sinai and fellowship at Yale. And she also did a research fellowship at Howard Hughes Medical Center Institute at the NIH since 1999. She's been at faculty at Rutgers since 2007 and is associate professor with tenure medical oncology since 2013. She's received several honors and awards, including Sarcoma Alliance Outstanding Patient Care Award, Dean's Research Award, Best Clinical Publication, Oasis Women in Leadership Program at Rutgers. She's a member of the American Society of Clinical Oncology, received a merit award with the society. She served on several committees at NCI, and she's been PI for many industry clinical trials, the cooperative group studies, investigator-initiated, and NIH trials for melanoma. So she spent a lot of years studying melanoma and treating the patients with novel agents, including immune checkpoint inhibitors. And she received a grant, an NIH grant in 2010, looking at, I think it's hydroxychloroquine in patients with stage 3 and 4 resectable melanoma. And she has more research coming on in the future using immune checkpoint inhibitors. She's published heavily in the treatments, the novel use of treatment with different types of immune checkpoint inhibitors for melanoma. So she's going to talk about rheumatologic toxicities from immune checkpoint inhibitors today. Thank you, Dr. Maynard.
Thank you. Thank you for the lovely introduction. So I'm going to try to share my screen here. Okay.
If you go to the green, there's a share screen at the bottom.
Yes.
And just hit that, and then you'll see your everything on your screen, and then you should be able to just share it.
Can you see that? Can you see it?
Not yet.
Oh boy. Okay. Let me see, because I did hit share the screen.
And then you should see your desktop and all the available windows you have open.
And it's not allowing me to do it. I'm so sorry. I'm hitting the share button.
Let me just make sure everyone has the ability to share screen. They should. You know what? Hold on. I'm going to make you the moderator.
Okay.
And then let's try that approach. The joys of technology. Let me just find you on the list.
Yeah, it's interesting. It will not let me hit the share button when I try to do that.
Okay. Try it now. You should be able to try it now. You see it? If you share screen at the bottom in green, and then it should open up all your various whatever screens you have open on your. Do you have it open? Do you have the document open?
I do.
If you want, you can email it real quick. I can just send you my email, and then we can answer for you.
It's not seeming to work, so I'm going to do that right now. Apologize for this delay here.
Okay, I'm going to put that in the chat. I put it in the chat. If you see the chat, you can just copy and paste that and send me your presentation. Okay.
Okay, so it is sent to you.
Okay. Maybe try it again. I just changed one of the things to allow multiple sharing. Try it again. Hit share screen again at the bottom. I just changed the settings, so maybe that'll help. And then you should see, it said whiteboard. It should say whether you have an iPhone or iPad plus any window you have open. It should show you all of them.
Yeah, it's just saying it wants to share the contents, and it'll give me a choice of my entire screen. But then when I hit the share button, it won't move forward.
Yeah. Okay. So let me just see if I have your email.
Oh wait, maybe that's why. Hold on.
No, that's my screen. That's me.
Can you see mine now?
No. Is there another document you have open?
No.
Okay. Just email it to me, and then we'll.
Yes, it's been emailed.
Okay. Hold on, it hasn't come yet. La da 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 da. Still nothing yet. That's, I mean, do you want to do some of the, can you do some of the, and we'll start if you'd like, and then I'll catch up if you want, once I get it. It's up to you. Some of the disclosures and things of that nature.
Give it a minute or two.
Okay. Nope, nothing yet. I've been getting emails, so is it a large file? Is it very large?
No, it looks like it was delivered at 10:02 a.m. to McCarretson at successcomgroup.com.
Yeah.
Folder.
Yeah, it could be slow. I have not gotten it. Mm-hmm.
Open. If I'm supposed to just be opening the PowerPoint presentation in my screen?
Yeah, if you open the PowerPoint, have it open and then hit share screen again, that should work.
Yeah, it's
Open the
not-
PowerPoint as if you're looking at it. You know, completely open it. And then once it's open, hit share screen.
All right, so I'm going to slideshow to play from start.
Yep. So don't even start the slideshow. Just have it open and then hit the
Okay.
screen and then start the slideshow.
When you click on share screen, do you see the options to pick your slideshow on, like, there's another screen that pops up?
No, I don't. That's, I think, the problem. It says I can share my entire screen, the application window, or Chrome tab. But if I share the
Yeah.
entire
There
screen.
you go. There you go.
That's
Well,
it, yeah.
we're seeing it.
All
You
right.
just pick. We're just not seeing the. Now pick your file. Go to the. Yeah, you're right there. Click on that. There you go.
Okay. All right. Sorry, guys. Thank you. for
Okay, no
bearing with me.
problem.
So everyone can see what I'm talking about then at this point.
Yep.
Okay. All right then. Sorry again. Thank you for bearing with me. And delighted to have the invitation to talk about immune checkpoint inhibitors, specifically as they involve manifestations of rheumatic disease. So just an overview. I mean, cancer immunotherapy has changed the world. And it's really interesting to understand that this is a paradigm that, you know, goes back to 1891 with Coley, and assuming that his there were toxins in the body that would, you know, potentially be responsive to immunotherapy. And the first immunotherapeutic approaches were begun all the way back then. In the late 1950s, we started to be able to transplant stem cells and either reinvigorate the immune system of a cancer patient or give them an immune system that's brand new from an allogenic donor. In the 1990s, we worked a lot with high-dose interleukin-2, and this is still part of our therapy, more for renal cell carcinoma than anything else. But by giving the cytokine back to patients, we were able to induce durable remissions, however, only in a minority of patients with a significant amount of toxicity. And along the way, we've had limited successes with things like interferon for the treatment, more adjuvant treatment for melanoma, but also in some kidney cancers, and imiquimod, BCG, and Ciplasel or Provenge for prostate cancer. 2011 is when we had the explosion of immune checkpoint inhibitors. And what I'll do in my talk today is sort of go over what these drugs are and what they do, clinical features of the toxicities as a class, and then toxicities specific to rheumatology. So the fact of the matter is that we had always understood that tumors sort of develop because your immune system falls asleep at the wheel. It's called immunoediting and immunosurveillance. Your immune system's in constant immunosurveillance to weed out disease, but something goes awry when the time comes for a tumor to develop, that it's sort of able to develop under the radar without your immune system eliminating it. And so it had been long thought that if you could tweak those interactions between your T cells, your dendritic cells, and tumor cells, that you may actually be able to make some progress in the war on cancer. And so certainly we have two popular classes of therapy, although I believe the future will hold many more, that work on the immune system checkpoints. One which blockades cytotoxic T lymphocyte antigen 4 or CTLA4, and the other programmed death receptor 1 or PD-1. And again, the point of these drugs is to sort of, as depicted on this slide, inhibit the interactions that keep your immune system in check and dampen down, to sort of gently rev it up enough to fight cancer, but not so much to create havoc in the body. And as you can imagine, the analogy that's often used is, you're releasing the brake on the immune system, as in the brake of a car. But if you can imagine, sometimes that you let up too much on that brake, and the immune system can go a little bit haywire, and that's where we wind up dealing with immunotoxicities. So anti-CTLA4 is an interesting compound. It was the first agent in a randomized trial to improve survival in melanoma, but it still wasn't all that great. It still has very little activity in other malignancies. I do have many patients who on single agent ipilimumab did achieve durable responses, but it was in the realm of about 10%. And so we often refer to this, when this drug was first approved, as a kindler, gentler interleukin-2, which is that first compound I spoke about. But the tail on that curve is a fairly significant long plateau at this point. And we need to understand that this is an important weapon in the fight against cancer, particularly when it's used in combination, as I'll talk in a second. And so right on the heels of CTLA4, and I was very, very fortunate to do my fellowship at the Yale Cancer Center with a physician named Mario Schnoll, who really was the godfather of this entire revolution. And I was among the first people to dose patients on trials with both CTLA4 and PD-1 in the country, which was incredibly exciting and really sparked my interest in cancer research. So we started to hear the PD-1 buzz in the latter half of the first decade of the century, and essentially, now we have an explosion, if you will, of tumor types where PD-1 is approved to treat cancer. What you see on this slide is a smattering of responses. Your most responsive tumors are the ones at the top of the slide. So cutaneous squamous cell carcinoma, exquisitely responsive, over a 50% response rate. Melanoma is up there. Tumors that have a mismatch repair defect. And then tumors that have proofreading defects, where the tumor, you produce a tumor that looks quite junky to the immune system, so it's exquisitely vulnerable to immunotherapy. Those are all on the high end of the slide, and will even respond to single agent therapy. Then you have your tumors that are notoriously unresponsive or cold, uveal melanoma, pancreatic cancer, and we're still working on ways to optimize immunotherapy for those patients. And then you have a lot of tumors that wind up in the middle. And are, many of which have PD-1 as a weapon in the arsenal that's been approved, for instance, non-small cell lung cancer, where even the somatic mutation is not quite what it might be for melanoma or cutaneous cell carcinoma, because there are smoking-related exogenous mutations. These tumors also can be quite responsive to anti-PD-1 therapy. And what is just so amazing is not the fact that tumors respond, because chemotherapy can make tumors respond, but the fact that the responses are durable. And there are many patients that we hold our breath and believe we've cured at this point in time. And that's not a word we've been used to using in stage 4 cancer. So, again, underlined in red, we have approvals for all those drugs. Underlined in purple, we have approvals for subsets of these drugs. For instance, breast cancer, the approval is limited to triple negative breast cancer. But the fact of the matter is that, this was a significant development in progress within our field. And so are 2 drugs better than 1? Well, certainly this is a slide that pertains specifically to melanoma. What we have found is that, in fact, the response rate is quite higher with the doublet therapy. The single therapy also, single agent PD-1 also gave very strong responses. CTLA-4 on its own, not so much, as I just mentioned. What we're learning, however, about these drugs now is that despite the fact that the combination therapy may not necessarily have significant differences in the response rates per se between the single agent arm, the durability of those responses is looking like it's going to wind up being much more significant. And so that for me is a game changer, because we may see more doublet therapy. And if we see more doublet therapy, guess what? We're going to see more toxicity. But again, we've got combination approvals in melanoma, renal cell carcinoma, MSI high colon cancer, all patients who, will ultimately, wind up developing some form of a side effect or other that will need expert management. So doublet therapy does, again, need more toxicity. 55% grade 3 to 4 toxicity rate in the melanoma trial that was pivotal for the development and approval of this combination. I will say that 55% grade 3 to 4, a lot of those were lab results that may not have been clinically significant. Nonetheless, these toxicities are not trivial, and they can be life-threatening, although to be honest, you can have life-threatening treatment in single agent arms as well. The name of the game with these agents is to maintain close communication with your patients. You've got to get out your expert diagnostician skills. You've got to be on the ball, and you've got to encourage people to let you know when something's going on. Because if you are able to address these side effects early, it will make all the difference. There are agents out there that target just PD-L1, which is the ligand of PD-1, atezolizumab, durvalumab, avelumab. And these are also gaining approvals in, for instance, bladder cancer. There's a little bit less published data on these subtypes, maybe slightly less pulmonary toxicity. Avelumab certainly has many more infusion reactions because the antibody has antibody-dependent cytotoxicity component to it, which was thought initially to perhaps give it a little extra kick, but may really just result in more infusion reactions. Important to remember that these are also a separate subclass of agents, but still to be treated with a high index of suspicion when you see toxicities develop that could be related to the immune system. So clinical features for these toxicities. Well, essentially, this is a scan of a very dramatic response in a patient who's had PD-1 blockade before and after treatment. So as you get tumor cell death and tumor cell elimination, you also have organ cells that are in the line of fire. And doing that, will you get organ cell death and organ elimination? Well, of course, that's possible. And I think understanding the exact mechanisms of these toxicities, who's going to develop them, and how we manage them is really the key piece of the future of oncology. These toxicities can be fatal. That's very rare, but it happens, especially when there is poor communication. I have to say the only times I have had significant fatalities are when patients are admitted to an outside hospital and I am no longer able to manage that case. And both of those cases, 2 of those instances in the last 11 years I've been doing this have been a colitis. So it's very, very important to remember that these things can turn ugly and to stay on top of managing the side effects. But pretty much pick any organ in your body and add itis to it, and there you have your spectrum of immunotherapy toxicities. It could be the lung, the colon, the liver, the pituitary gland. Neurologic, I've seen Guillain-Barré, I've seen MS-like pictures, adrenal insufficiency, myositis, myocarditis, hematologic, including recalcitrant ITP, and nephritis. I mean, anything that you can think of that can be inflamed will happen. The good news is, again, it's pretty rare for things to be life-threatening. And interestingly enough, it's very rare for all these side effects to happen at once. It usually tends to be, your immune system seems to only be able to focus on 1 or 2 organ systems at a time, which is very fortunate for the patient. But this is like nothing we've ever seen before. So again, you've got your fairly common side effects, and those include endocrinopathy. It could be a fulminant hypophysitis, or it could just be a hypothyroidism, hypothyroid picture where you need thyroid replacement. Pneumonitis, hepatitis, colitis, arthritis, and rash. These are among the more common things. And then again, you always got to have your diagnostic hat on. It could be, things like encephalitis, uveitis, myocarditis, pancreatitis, and type 1 diabetes, gastritis, nephritis, neurotoxicity. Again, anything is fair game. A common theme here, though, is inflammation. And so when I think about the immune system, I liked this quote, which I stole from one of my colleagues. He says, it's sort of like an Anna Karenina principle. All happy families are unlike. Each unhappy family is unhappy in its own way. All well-adapted systems are alike. All non-adapted systems experience maladaptation in their own way. In other words, when things are going well, they go really well. Think about, an auto body assembly line. One kink in that assembly line gets messed up and you've got some trouble on your hands. That's what dealing with an immunotherapy toxicity is like. You don't know at which point in the very complex milieu of the immune system things got messed up, but certainly can make haywire for an entire body. So do you need the toxicity to get outcome? Well, it's a little bit unclear as of yet. It seems like there might be equivalent outcomes of toxicity or no toxicity, possibly if it's severe toxicity, slightly worse, which makes sense because patients may then be susceptible to complications from that toxicity. And certainly I have patients where, things go off without a hitch. It's like I'm giving sugar water, and I have patients where things are quite rough. It does seem that more of our recent data is showing us patients that developed a cutaneous toxicity may have an improved outcome. But again, we're still learning. These are still relatively new agents. So who develops these side effects? Well, that's going to be an important thing for patients in your office who may develop cancer that we are going to have a conversation about, or it may also be important for when patients have already started therapy and we're trying to figure out what their risk score is. And so autoimmunity, it's been a bit of a mixed bucket. And it's difficult because to date, these patients have all been excluded from clinical trials. They seem in the anecdotal reports we have to have equivalent response and toxicity rates, frequent low-grade flares of conditions, and largely mild cases. But the best data we have are, case reports like this one, which we were able to publish in JAMA Oncology, and sharing things in a very non-sophisticated, non-rigorous way. So to answer that problem, NCI number 10204, which will be open at Rutgers, is trying to gain prospective data in cohorts of patients that have pre-existing immune diseases, and several rheumatologic diseases are definitely part of that trial, as well as some of the GI diseases and lung diseases as well, which are autoimmune in nature. Predisposing factors, well, in terms of organ dysfunction, so yeah, again, we're in the same boat. Patients are excluded from all these trials. They've had slightly lower response rates in our data to date, but again, a lot of these people have poor performance status and other comorbidities to deal with. The toxicities haven't really affected one organ versus another, although certainly you can imagine patients that already have heart, kidney, or liver dysfunction, volume overload is going to be a tremendous problem throughout the course of treating them for their disease. And then finally, patients who have had a transplant. So what can we do with these patients? Well, we obviously know that any of these patients, when we're treating them, we're usually not treating them in an adjuvant setting, meaning, trying to keep the cancer from coming back. We're treating them when it's a life-threatening situation because they've got a 50+ risk of their graft failing. And certainly the most important thing I do with these patients when they're in front of me is have a very, very honest discussion about their goals of care. I have had, kidney patients look me in the eye and say, there's no way I will do anything that would make me go back on dialysis. And then I have some who say, I've been on dialysis, I can live with it. I can't live with this cancer. So talking to the patient and having a clear understanding of what's in store for them if the graft is to be lost is very important. It seems to be, again, independent of timing of delivery of the therapy. Generally, again, we say we're not going to give these, anti-cancer therapies unless it's a life-threatening situation. And then there are patients who respond and are able to keep their graft. It's a slippery slope, and it's tricky, and something that will require, again, very close evaluation in the future. So the perfect storm we have right now is that cancer is common, immunotherapy is common. Throughout the state, this is part of every single oncology practice, where maybe perhaps 5 years ago that wasn't the case. The rate of any toxicities are common, although fatalities are uncommon. We've become increasingly subspecialized in American medicine, and sometimes that leads to poor communication, and something we really need to work on in this space. And finally, the vast majority of physicians are not equipped to deal with immunotherapy toxicities. You may have never seen one of these patients and not know how to manage, and that's why we're here to provide expert consultation and assistance in any way, shape, or form possible. So let's talk about toxicities that are specific to rheumatology. The spectrum of disease noted, again, it can be anything: arthralgia, arthritis, myalgia, myositis, PMR, lupus, Sjogren's syndrome, or exacerbation of any known rheumatologic disease that patients may have to begin with. I bring up cardiac toxicities because they do happen. I have been extremely fortunate to never have a case. What seems to be interesting is that, although there's still not published data, the myocarditis cases seem to be popping up in specific pockets throughout at least the United States, where my colleagues in Roswell Park have several cases. My colleagues in Nashville have had several cases. I've been fortunate to never have a case. And so why that should be, it doesn't appear that cardiac toxicities that develop have associations with other underlying cardiac issues like ischemic heart disease or CHF. So it may indeed have something to do with, HLA patterns or genetic patterns of populations living within a specific area. We still really don't know what to do in this boat. But I will say that when these toxicities happen, they tend to be very dramatic and can be fatal. So it's important to have, again, a high index of suspicion. If somebody has chest pain, you can get a CT to look at pneumonitis, but if that CT is negative, don't stop there. Order additional evaluations. Now that we've recognized this as a toxicity, we're seeing a rapid increase in reporting of the cases. But again, we're still learning. Combinatorial therapy obviously is more of a risk than single agent therapy. Again, there doesn't seem to be a great association to the known normal predictors for heart disease. And again, this is another slide just saying that we have a low incidence. What do we need to do? We start with methylprednisolone and then can add on other agents like IVIG. ATG has been published in case reports and close consultation with experts in the field because this is a very serious complication. So in terms of specifically rheumatologic disorders, let's look at the toolbox that we have. You can, especially if a toxicity is grade 1 or 2, start with anti-inflammatory over-the-counter medicines, simple as Motrin. Steroids usually quickly become a treatment of choice, starting at a dose of 0.5 to 1 milligrams per kilogram. Although we'll do a couple cases in a minute, and in those situations, I will review the doses I did wind up starting with these patients. Sometimes, if it's a grade 1 toxicity, a Medrol dose pack will do the trick. It will really depend on the patient in front of you. Hydroxychloroquine, methotrexate, anti-tumor necrosis factor, and anti-IL-6, definitely all parts of the puzzle, usually only after steroids and anti-inflammatories have failed. Remember, these toxicities can often regress quickly. Sometimes they do recur, especially on a steroid taper. That's usually the point at which generally we bring in the other more serious immunosuppressants, because don't forget, those confer their own cancer risk. And multidisciplinary care and close communication is imperative. Please share your cell phone. Talk to the people who are helping you take care of your patients. If they get admitted to the hospital, call them. It can make all the difference in a patient's outcome. So this is a slide I took from a recently published rheumatologic review, which sort of reviews, again, some of the categories of meds I just put up there, and potential side effects, time of, onset, and the effect on cancer risk. And to recap sort of what I was just saying, NSAIDs obviously, have their usual side effects of GI side effects. There are some cases that can be treated with NSAIDs alone, although I find they are increasingly rare. Corticosteroids, again, patients can feel almost, immediate relief within a couple of days. And in general, this is safe. The only problem is when you have someone who's not experienced with steroid, with the use of steroids, and I'm probably not talking to anyone in this audience, but I have seen patients, referred in by inexperienced providers that are on a tremendously long steroid taper. And what does that do? It sets that patient up for other complications. So you can taper, over 3 to 4 weeks for a grade 2 or 3 toxicity, but you've got to bring patients back in for phone calls, bring them back in for visits, and don't use what you don't need. Obviously, you can then have some of our DMARD drugs. Again, we've mentioned methotrexate and hydroxychloroquine. And then, usually, by and large, these are considered safe options. And then obviously, as we're, moving into our more heavy duty drugs, where we do start to worry that, yes, there might be a cancer promoting effect if we have to use these. So things to consider as we're instituting our treatment algorithms. So general principles: if something's grade 1, you can manage symptoms, continue therapy. If something's grade 2, manage the symptoms, possibly add steroids, hold the therapy, and can resume with a prompt resolution. And if grade 3 or 4, stop the therapy, start high-dose steroids, don't re-challenge, don't try to treat through the toxicity. And so again, for grading, if you want to dramatically oversimplify how we grade things, grade 1 or 2 is mild to moderate, grade 3 requires the hospitalization, grade 4 is life-threatening, grade 5 is fatal. So now we've got lots of algorithms, we've got lots of good articles, we've got lots of good references, but I must say, remember, these are algorithms. You've got to look at the patient in front of you. Even if it's something is technically grade 1, and if it's been going on for weeks, you've got to do something about it. You've got to address it. Similarly, if patients are grade 3 and they're, either or the diarrhea has been going on for weeks, it's not the time to start them on a new therapy, right? We've got to fix the problem that's in front of us. And that's an oncologic and a rheumatologic principle. And I've seen cases of unresolved toxicity sort of lingering for whatever reason on a grade 1 algorithm, even though it's been going on for 2 months. And you start a little bit of steroid in the patient and it's like they're a new person. But I would say, again, any grade 1, effect, and again, you could use thyroid or pituitary, but any grade 1, you obviously have to replace, the physiologic problem, but you continue therapies. And anything that's more serious, or I would say that pneumonitis as a grade 2 is equivalent to a grade 3 AE. You've got to hold your therapy and discontinue if there's no improvement back down to a lower grade toxicity. So let's talk a little bit about some of the classes of the rheumatologic manifestations we might see. The most common is arthralgias, myalgias, and PMR. And they're usually mild, but they can be severe. It can be just annoying to completely debilitating. I will say the trick that makes me look like a Jedi Knight is if somebody's on a statin and they start developing this, before you do anything, you stop the statin. The pain can dissipate immediately. And that's a mechanism that I'm sure has not yet been deciphered, but at least in my hand seems to be quite dramatic. And a lot of times these patients do wind up on steroids, although occasionally they need more. I might start with a Medrol dose pack if somebody doesn't respond to anti-inflammatories. And sometimes the Medrol dose pack clears it up right away. Sometimes as soon as they're tapered, they start to feel it again. And in that case, I usually start a steroid dose, again, at 0.5 milligrams per kilogram. And that's usually at the point at which I have a rheumatologic consult involved. More often than not, when I work with the community rheumatologist or academic rheumatologist, patients will stay on the steroids for a bit and then get transitioned to something usually Plaquenil in my experience, but sometimes methotrexate for maintenance. So lupus and lupus-like disorders can develop. Again, it's a great masquerader, just like lupus itself. You could have just cutaneous manifestations as the only sign. And sometimes it's hard to pick this up between something that's developing into a true, cutaneous lupus and the regular anti-PD-1 or anti-CTLA-4 rash. And that's why I think it's important to biopsy a recalcitrant skin manifestation. There's no harm in starting with a topical skin cream or, a steroid taper initially. And if the rash goes away and there's no issue, then you're good. But if things keep coming back or keep recurring, then it's important to biopsy it, because it may be something more than just a regular maculopapular autoimmune rash, and it may need more intensive treatment. And again, steroids are a mainstay of this therapy, occasionally more. I have several patients who had cutaneous lupus, biopsy proven, again, started on the steroids and transitioned over to hydroxychloroquine at this point in time. And so catastrophic systemic immunologic cascade can also happen with major organ compromise. Sometimes, rarely, thankfully, I have seen patients treated with doublet therapy that then turn and present with, a wildly elevated CK to rhabdomyolysis-like picture where hospitalization and ICU care is indicated. Cases like this, we start with steroids, high dose, but usually more is required. I've only seen 2 of these over the years, but they do happen, and it's important to know what to do when this does happen. So let's go through some cases. Case 1, I have a 70-year-old male with a performance status of 1 and hyperlipidemia. He received single-agent anti-CTLA-4 adjuvant therapy, followed by anti-PD-1 therapy when his disease progressed. He was status post just 3 treatments of the anti-PD-1 therapy, and he would tell me that he felt like he had a toothache in his fingers. And he would also complain, I can't do a push-up. So again, not necessarily something that really interfered every day with his life, but enough to actually require, intervention at this point. And so, just like the boards do, I listed a bunch of choices because honestly, at the end of the day, in some way, shape, or form, they're all right. You could start Motrin and stop the statins at the same time. If that doesn't work, you can start steroids. If a patient requires continuous steroids beyond a measurable dose pack, it's time to engage a rheumatologist for continued continuity follow-up and care of the patient. Okay, case 2. I have a 65-year-old man who had 9 months of single-agent anti-PD-1 therapy, which is the gentlest of the immunotherapies. And he walked into clinic one day, anemic to 10.9 when he had previously been normal. His scalp was tender, his shoulder girdle was sore, and he had a fever to 101.5. And so again, what are your first concerns? Well, we did all of the above. We got a hemolysis panel, we got blood cultures, made sure he wasn't infected. Because remember, common things are common, and it's important to remember your medicine and rule those things out first. We started steroids. After we got the blood work, we obtained a rheumatology consult. And he did truly have a PMR-like picture. He was maintained on the steroids. He was lost to follow-up for a little bit, unfortunately developed a rectal abscess, which was probably a direct consequence of a steroid taper that wasn't managed properly. Ultimately was hooked back in with us, was able to get also hooked in with his rheumatologist, tapered him off the steroids. He's now maintained on a very low dose of hydroxychloroquine, and he's doing great. Case 3, I've got a 63-year-old woman with disseminated metastatic melanoma, life-threatening, treated with ipilimumab first. It was adjuvant therapy at the time, followed by nivolumab, which is anti-PD-1. She developed a plaque-like rash on extensor surfaces. This was recalcitrant to steroids. She ultimately had a biopsy, which was consistent with discoid lupus, and a brisk lymphocytic infiltrate. So this patient actually has been managed with dermatology and by me. She, I believe, saw a rheumatologist at one point, but has pretty much been under the care of the dermatologist. Steroids, again, actually had an appropriate dose and an appropriate taper. She does not have the best performance status, and she actually developed a very significant infection. So we got her off those quickly. Just saw her recently. She's disease-free and is maintained also on hydroxychloroquine. So case 4. So this was an interesting case. The patient actually started with a or an immunologic condition. She was admitted to the hospital with spontaneous rhabdomyolysis. They worked her up from top to bottom, could not find a cause for this, but it was certainly life-threatening, requiring an ICU stay. Finally, muscle biopsy was done and was found to have autoimmune necrotizing myopathy, and she was put on treatment with steroids and Imuran. 10 months later, she presented in my office with metastatic melanoma. And the question at that time was, geez, what do we do? This lady almost died from this disease. Do I dare re-challenge her with a checkpoint that could rev up whatever process was going on before? And again, this is where having a very clear conversation with the patient about what their goals are and what the risks are imperative. Because you could have said, hospice, I'm not going to do anything. Chemotherapy, because we can't touch immunotherapy because we can make her very sick. Try therapy with a single agent checkpoint and cross our fingers and see what happens, or go in with doublet therapy, which many people would say would be the standard of care right at this point in time with someone for her disease. So we chose her community oncologist who referred her up to me, and I chose option B. She did obtain a response. 30 to 40% of patients with melanoma will respond to just one drug. And she did not go back in, thankfully, to her spontaneous rhabdomyolysis. We also stopped her Imuran at that point in time and sort of just watched her exceedingly closely. She has had a disease relapse within the 5 years that I've been taking care of her, which we've been able to rescue with the re-challenge of the anti-PD-1 and surgery. And so what this goes to show you is just because somebody has a very serious condition doesn't mean that you may not be able to get through it if you're very careful. You can't predict what's going to happen. That's the bottom line. And you have to be honest with patients about that. But the fact of the matter is that this lady's done exceedingly well. And had we been too timid to try, we may not ever have known that we could get through this. Case 5, I've got a 53-year-old male who had a history of melanoma and wound up developing 2 potato nodes after a course of interferon therapy, which thankfully will never be used again as a standard of care for adjuvant melanoma, but for a long time was all we had. He had an elevated asymptomatic nodes on scan, and he presented with galloping disease. And so the tragedy is that this case was in 2011. It was on the brink of anti-CTLA-4 being approved, but it was not approved. I could not prescribe this agent for this man off protocol or off expanded access, and I could not get the agent for him. So your choices then were really just A and D, chemotherapy and hospice, and we chose hospice. The choices now would be single agent checkpoint, doublet therapy, chemotherapy, or hospice. And this is a patient in today's day and age where I actually would prescribe the doublet therapy. Interferon-induced sarcoidosis is asymptomatic in a patient where the disease is just going to take over in a matter of weeks. 2 drugs, again, could be risky, may need to manage, side effects or a flare of the sarcoidosis, but you don't know what will happen if you aren't able to actually try to give the course of therapy that may be the most effective against the disease. Again, all with a very, very frank risk-benefit discussion with patient and family. So the take-home points. I think that we need to involve oncology and content experts early for suspected toxicities. Treatment algorithms are available and published for any side effects that develop. I think this is a fascinating area of clinical practice and research. We need more organ-specific experts. This is something where you could organize an entire team of medicine subspecialists and a database of tissue and blood and stool. And certainly, our premier institutions like Mass General, for instance, has done a beautiful job in organizing a repository that they will learn an enormous amount from. This is where the future is in oncology, because if you can figure out how to spare somebody side effects or who won't respond, that's really the holy grail of what we're trying to achieve. However, remember, algorithms are algorithms. Do not forget the art of medicine. Look at the patient that's in front of you. And remember the zebras, because you really can find some very interesting details in managing these cases as you move forward. I think the challenge, again, developing that toxicity service, who's going to find that of value, who's going to pay for it, who's going to support someone to do it, give them the time and the resources they need. It's really, in my opinion, again, something that's just so important, but you know, it obviously takes a village. We need excellent diagnosticians, right? I think we have become very protocol happy in medicine, and we've got to remember protocols are great, but you know, you've got to actually look at what's going on too. Fear of steroids is not allowed. I see that a lot of times on inpatient services where, you know, there seems to be a concern to get, you know, started with steroids. We just got to plow through sometimes and, you know, not be worried about the consequences of not starting steroids early are probably worse. And certainly I've had my own challenges with this, and now the COVID era, where when patients are presenting with symptoms, I don't know if it's their immunotherapy tox or is it a brewing COVID infection. So really having prompt evaluation, prompt access to care is really important. As I said, I think this is a fascinating area moving forward. I think we have to remember and educate the healthcare providers that are on our team. You know, you cannot run a clinic like this without expert nurse support. And you have to remember that these nurses are subject to something I call teletoxicity. My nurses are always constantly on the phone, constantly answering emails. And we've actually generated data at our most recent international meeting showing that, you know, that has to be built into, you know, the evaluation and the algorithms by which we provide support to these clinics, right? It's very different from chemotherapy. And so remember that you're only as good as your team, and spend time with your team, spend time educating them. Most of them will find it very, very gratifying to be part of a team like this. It's an enormous opportunity to set guidelines across our health system in general. And I think that any health system, not just ours, would benefit from an organized approach to this. So I will be moving on from Rutgers as of July 1, but my cell phone will stay the same. I would say if anyone has any questions, referrals, assistance, feel free to bother me. Quote, bother, it's never a bother. I share this number liberally because I think that it's important for us, again, to be able to communicate and help each other in cases like this for the benefit of the patients. And with that, I will take any questions. Okay. So I think, can everyone hear me? My first case is, did case 2 get a temporal artery biopsy? He did, in fact. And he did have findings that were similar to what we would have expected for a PMR-like picture. So another question is there a certain complications that respond better to TNF inhibitors? And do the TNF inhibitors tend to work better? So it's a really good question. And I would say that it's something that we don't have a lot of information on. You know, I've been fortunate in my own practice. I haven't had to go down that road. And if I did, I would be doing it again with a fairly, you know, significant, you know, questioning of whether or not, well, you know, we really need to, you know, bring those agents out because of the risks that are involved. That being said, they're there for a reason. And if we need to use them, we can. Another question is the appropriate IARE that might respond to something like tocilizumab or saralimab. So we actually have a trial at NYU that's first line looking at the combination tocilizumab with immunotherapy up front. And that was more to, you know, suppress you know, the IL-6 activity, which can relieve to resistance. But it'll be interesting to capture data from that trial, especially the rate of pneumonitis, as we've been watching, you know, the tocilizumab story and saralimab evolve in front of us with COVID. Again, I think we don't have a lot of data, and it's going to be a really important place to watch in the future. So here's a very important question. Am I concerned of diminishing anti-cancer effects by treating with corticosteroids or anticytokines? So corticosteroids, not so much. You know, again, there's some data that I showed earlier that, you know, the treatment, you can't be afraid to start steroids in these patients. Patients also, I've noticed, will underreport their symptoms because they, you know, people have a real fear of not getting their therapy. And that's not the way immunotherapy works, especially when you're doing doublet therapy. Sometimes, you know, 2 or 3 doses is more than enough. And, you know, I've had patients where they've had a complete response to only 1 dose of doublet therapy. So I think it's one thing we have to be very clear with the patients on is that, you know, your immune system is unique to you. You may not need all 4 doses. If you're having side effects, you have to tell us because your life literally depends on it. And essentially, you know, I think that the important piece to recognize is that, you know, everybody's different. Everybody's body is different. But certainly if steroids are needed, they should be liberally given. So if Plaquenil is needed, how long are patients on it? I don't have too many patients who I've been able to taper off if Plaquenil gets, you know, gets instituted. I will see, you know, a lot of, you know, colleagues, rheumatologic colleagues saying we're going to try this for 6 months and then we're going to see if we can taper 6 to 12 months. But a lot of my patients, once they're on it, they wind up staying on it for a bit. I have not encountered any kind of associated vasculitis in these patients. Doesn't mean it's not possible. I just haven't seen it. It is very a similar, you know, similar side effect to something like GVHD. And a lot of times, again, so if you know, this is more in when patients are come in with a, you know, if we have to treat somebody with an allogeneic transplant and their GVHD, you know, really rears, which it often does. This is always in very, very lockstep, you know, consultation with the transplant team. So yes, we can use, you know, other agents, but it's obviously on a case-by-case basis, and it's never done without, you know, their transplanter being involved. Okay. I think I've gotten most of the questions that are popping up here.
I know Vivian's had some trouble getting on. Vivian, are you on? There you go.
Oh, okay, I'm sorry, Janice. I just joined again. I'm having trouble with my Wi-Fi. Thank you so much for your talk. I got most of it.
Okay.
The talk. I don't know if all the questions were answered. I think so. You know what? I had a question in particular. Even though we use steroid and we use Plaquenil and we can use methotrexate, how do the patients that develop these toxicities fare out in the long run? Do they do worse compared to those that don't develop these immune-related toxicities, and is mortality any different from your experience with these types of cancers?
It doesn't seem to be the case. Again, we're still learning, and the cutaneous toxicities, there may be a relationship, but I have patients, I saw somebody yesterday I treated him in 2013, and he's been on vivaprednisone for, you know, RA type picture. He's doing beautifully. So there doesn't really seem to be that much of an association. You know, obviously, I think we have concerns if we have to employ more heavy duty immunosuppressants that we could, you know, sabotage the immune system response to the cancer. But a lot of this really just depends on, you know, the volume of the disease when we start is a huge predictor of how people do. If somebody has skin lesions and lymph nodes, they will often do just fine with even only one drug. When someone has liver and brain mets, it's much harder to treat. So I think it doesn't really seem to be dependent on whether toxicity develops or not.
I think Vivian's frozen again.
I think she is as well.
Yeah.
May I ask one question?
Sure.
What is your opinion of using anti-TNFs in melanoma in general?
So, I mean, I think it's sort of in the same ballpark, you know, as you know, any other drugs outside, you know, your initial top rung of, you know, steroids, Plaquenil, et cetera. You know, if you need to do it, you certainly can do it. Do I stay away from it if I don't have to do it? Sure. Because I think, you know, we still worry. We just, you know, the fact of the matter is we just don't have great data, right? And we're trying to fix that, but it's going to be a while before we have anything rigorous.
Okay, I don't know if Vivian's on again. So again, the trials and tribulations of maybe that's her. Does anyone have any more questions? Okay, well, thank you very much. And I'm sure Vivian, when she gets back on, will want to thank you. I think it was very informative. Our next speaker, we ready to go with our next speaker? Hold on, let me see if Vivian's on. I can text her real quick. Hold on. I will call Vivian real quick. Are you on? Okay, who's our next speaker? Okay. Anne, are you ready with your presentation? Is Anne on?
Her image is up on the screen. Her microphone is muted.
Yes, let me unmute Anne.
So I wanted to introduce her. I'm wondering if you can just use my.
Yeah, Anne, you're unmuted. Anne, if you can, are you there, Anne?
I'd like to introduce her if possible, but I'm even having trouble with my cell phone. I don't know what's wrong with this whole system that I have.
No, there's a few people. Who is sharing screen right now? Is that Anne?
Alex Kimmel.
Okay. Okay.
Okay, can you hear me now?
Yes, we can.
This is Anne. I just have to figure out how to share my screen.
Just hit the share screen at the bottom.
Yeah, I don't see it.
It's a green. It's next to the chat. It's you'll see you've got at least my icons. It's mute, start video, security, participants, chat, and then share screen.
All right, I'm getting there.
Yeah, I'll while you're looking, I'm gonna put a Vivian on. And Vivian, you can speak.
But I have to do it remote because I'm not able to log in.
I have you.
And welcome. I'm sorry, I'm having trouble with my Wi-Fi here, but I just want to introduce you. So welcome to our meeting, and thank you for coming. And I just wanted to summarize that Anne is going to talk about the world of CPPD in 2020. She attended the Johns Hopkins Medical School and trained at University of Rochester and did a fellowship at Medical College of Wisconsin. Graduated in 1990, which is not too long ago, and has been a faculty since 1990 at MCW. She is currently Will and Kava Ross Professor of Medicine, Chief Rheumatology since 2000, Director of the VA Translational Research Unit since 2008, and Associate Dean for Research at MCW since 2019. She's done lifelong research in CPPD diseases. She's had grants. One grant is to study the effect of TGF-beta and EGF on pyrophosphate production by cartilage. She has other NIH grants pending on this very talk. She's published in many peer-reviewed literature since 1989 on pyrophosphate production in cartilage and chondrocytes, as well as aging of cartilage.
And she's also authored many chapters and updates on crystal arthropathy, CPPD, pseudo-gout, as well as a review in the New England Journal in 2016. And thank you for coming. I'm going to mute myself so that we can hear you now.
Thank you. And Ann, by the way, try Alt S, and that should allow you to share your screen.
Okay.
There you go. There you go.
That is looking better. Let me get rid of that.
And just go to the bottom of your screen and pick on your PowerPoint.
Pick on my PowerPoint.
Yep, there you go.
Put on the slideshow and go to the right. Let me just end the show and go to the right slide.
And we all learned Alt S. That's our new Zoom trick of the day. Alt S for all of us.
Isn't that good to know?
Yes.
Let me, okay. Am I here? Is this working? Yeah. I want to thank you, particularly Vivian, for this invitation to speak about CPPD, and I consider it a virtual invitation to New Jersey, which you can interpret as you see fit, but I'm very excited about virtually visiting New Jersey right now, and I love to talk about CPPD, so I am very excited about the opportunity. So Vivian helped me with this title, which is The World of Calcium Pyrophosphate Crystals in 2020. And as I said, I'm kind of excited about CPPD right now, which is not something that I could say a couple of years ago. So unfortunately, I have no disclosures because there are no approved drugs for calcium pyrophosphate deposition. And I want to just start by just making sure that we're all talking about the same thing, which is a challenge with CPPD. And I define CPPD as arthritis caused by CPP crystals or calcium pyrophosphate crystals. The nomenclature, as many of you know, of CPPD was dealt with by EULAR probably now maybe 8-10 years ago, and is very awkward. So you will see me pretty much revert to old terms, including pseudo-gout. But the overall picture is I'm going to talk about calcium pyrophosphate deposition. I like to sort of separate that from calcium pyrophosphate deposition disease, which is clinical manifestations of calcium pyrophosphate crystal deposition. So the disease definitions, I'm very excited to say, and classification criteria are finally being pursued by ACR EULAR, and we are just starting those steps. But I think that one of the many challenges of CPPD is the nomenclature, which is awkward and inconsistent, and is really a problem. So today I thought I would briefly review some new and important clinical aspects of CPPD. I'm going to discuss some new associations, both metabolic and hereditary, that are really causing major changes in the way we think about the pathogenesis of this disease, and talk about these new findings in regards to pathogenesis that really question the concept of CPPD as a cartilage disease. And it has always been, since its inception in 1962, really felt to be a disease of cartilage. So this is really paradigm shifting in terms of how we think about it. I think right now there are many exciting things about CPPD. I think people are beginning to recognize its importance and the high frequency of affected patients if one looks carefully for them. There are some new diagnostic modalities, which I'm going to talk about, and we are gaining ground in understanding its pathogenesis, which I think will ultimately result in some exciting new therapies for this very frustrating to manage arthritis. So I used to be quite sad when I talked about CPPD, and now I'm really excited. I think it's a great disease to study and very exciting about potential interventions. In terms of clinical presentations, another challenge of this disease is that there are multiple manifestations of CPPD. And the one people probably think is most common is asymptomatic chondrocalcinosis. So just a radiographic finding of calcium pyrophosphate deposition without clinical symptoms. We have no idea how frequent that is. Acute pseudogout in the EULAR nomenclature known as acute CPP crystal arthritis, which is quite a mouthful, is probably the manifestation that we all recognize most frequently. The chronic arthritis can look very much like rheumatoid. It can be relatively non-inflammatory and look much more like osteoarthritis. And then there's an increasing literature on unusual or less common manifestations of CPPD, including spinal involvement, with probably the best recognized manifestation being crown dens, and then a Charcot-like arthropathy. I think it's important to remember too that these manifestations are not mutually exclusive, and patients can start with a presentation that looks very much like acute pseudogout and then develop something that looks more chronic. So it'll be great to have clinical classifications, but they're not going to be mutually exclusive. I want to reiterate what I said about crystal arthritis being an expensive disease. This is literature from France in 2011. With the annual cost of hospital stays for crystal arthritis was a considerable amount of money. And in this study, what was interesting is they had a very equivalent amount of gout and pseudogout. So it is really an important cause of hospital stays and extensions of hospital stays, particularly around elective surgery and other illnesses. And I want to take a little bit of time to sort of present a typical patient that I see with CPPD. A lot of people say they don't see much of this disease, and I think it's probably because they don't look very carefully. But I think this patient really nicely illustrates some of the relatively unique characteristics of this disease. So this was a 79-year-old woman who was referred to me for a second opinion, had a great rheumatologist who had cared for her for many years. And the really reason for referral was, kind of, is my diagnosis right? And she's, she just has responded terribly to everything I've tried. That's very characteristic of CPPD. She had onset of inflammatory arthritis in her early 40s, which was seronegative. Involvement of her hands, shoulders, hips, knees, and feet, and I'll show you her x-rays in a moment. Interestingly, she had early onset osteoporosis and had had terrible problems with spinal and long bone fractures. A family history of severe arthritis in her father of unknown type, and she had been maintained most recently on methotrexate, hydroxychloroquine, zoledronic acid for her bones, long-acting morphine, and PRN oxycodone. So lots and lots of pain. Interestingly, she had worked in a hyperbaric oxygen clinic at some point, or for an extended long period of time, and people were interested to think about that in terms of her clinical symptoms. Joint exams showed severe subluxation of her PIPs. She clearly had synovitis in PIPs, as well as in some Hebriden's nodes, and at the second and third MCP on both hands. Synovitis over her wrists, which was very symmetrical. She had no focal spinal tenderness when I saw her. She'd had extensive surgery on her, on a knee, was missing a patella, and no knee effusions, and she was tender in her ankles and feet. Lab evaluation, normal PTH, calcium phosphate, iron, and transferrin, a low normal alkaline phosphatase, but not low normal enough to get excited about. She had mild anemia, a slightly elevated rheumatoid factor, which in most cases I would have ignored. Normal sed rate and CRP at the time I saw her. A really bad DEXA score, and she had never had a joint aspirate. So these are her x-rays, and I think the salient findings are, you can clearly see, I hope, chondrocalcinosis in the triangular cartilage in her wrist, as well as around the base of her thumb. And she has this very destructive arthritis in some of her PIPs, as well as this sort of what some radiologists call gullwing appearance of her Hebriden's nodes. Her spine film, I think, just reiterates the severity of her osteoporosis with multiple compression fractures. So in terms of diagnostic possibilities, she has been called for years seronegative rheumatoid arthritis, and that indeed may be her correct diagnosis. The diagnosis of erosive osteoarthritis was also entertained for this woman, or just plain osteoarthritis. AVN, particularly with her exposure to hyperbaric oxygen, was entertained. But the question to me was, could this all be calcium pyrophosphate deposition disease? And I think that's an interesting question. I think it's a hard question to answer with any degree of certainty, but there are certain features of what I thought was so illustrative of this woman. You know, the diagnosis of CPPD is often not easy. It's often sort of a diagnosis of exclusion, or it's an additional diagnosis to something else that's underlying. We know that it significantly overlaps with osteoarthritis, so it can be very hard to tease that out. It overlaps with rheumatoid arthritis, and there's been a lot of interest in this, you know, the group of rheumatoids that are seronegative and whether a significant amount of those may actually be calcium pyrophosphate deposition. I'm going to talk about this interesting connection with osteoporosis, which sort of has led us into the bone world in the pathogenesis studies. And it's often really difficult to manage, and I think more painful than a lot of other arthritides. So the fact that this woman required narcotics, I thought was very interesting. So let me move on to some good news, I hope, in the diagnosis world. The gold standard of diagnosis of CPPD, I'm sure all of you know that, is finding calcium pyrophosphate crystals in synovial fluid of the affected joint. And this sounds like, well, that's easy, but it's not. You know, even I will occasionally miss CPPD crystals. Many CPPD crystals are not birefringent, and that's been shown over and over again. They're sparse, they're small, and some of them don't look very crystalline. They look, they have this sort of almost what I like to say globular appearance. And so there are two tricks that I think are helpful. In our CPPD colleagues in Spain have a trick of turning up the light, turning off the polarizer, and using a 60x objective to see non-birefringent CPPD crystals. And they've also done some really interesting work on the shape of the crystal in regards to its birefringence. So these beautiful rod-shaped crystals are often not birefringent or as brightly birefringent as these sort of blobs. And so knowing that, I think, helps a little bit when you're looking at synovial fluids. There are two groups in the country that are very interested in looking at kind of novel microscopy methods, and this is the group from UCLA, which John Fitzgerald has been working with, that have a new lens-free microscopy method. It's worked fabulously for gout crystals. Interestingly, it may be a cell phone app at some point, so another great use of cell phones. And I think that that is really exciting to think about using some of these other modalities. There's a group in Cleveland, too, that has looked at a scaled down Raman spectroscopy unit so that you could actually do, you know, advanced crystallography at the bedside. So you get a chemical analysis of the crystal, and I think that would be really exciting. I'm not going to talk a lot about radiologic modalities because I'm sure you are all familiar with the fact that ultrasound is very good. Plain X-rays are excellent at picking up chondrocalcinosis. CT scans are also very good. MRI is not a useful modality typically for looking at calcified tissues. And there has been, a really slow progress in adapting dual energy CT, which gives these gorgeous gout crystal pictures to CPPD. It has worked really well in gout, as many modalities do, and they're still using ex vivo samples to play around with dual energy CT. And the problem, of course, is that both phosphates, pyrophosphate, and calcium, all of those are major components of bone, and some in cartilage, particularly in osteoarthritis. So that the differentiation of what's in the bone and what's outside the bone is very difficult. So that is not ready for prime time, but may at some point be. I think the other really exciting thing about calcium pyrophosphate right now is that, I know that you heard Dr. Loser talk about osteoarthritis this morning, and I think the current thoughts about osteoarthritis is it's probably a common end point of a lot of different pathophysiologies. And I think CPPD, or the presence of these crystals in the joint, really represent an important and consistent and perhaps very unique subset of OA. And this looks at the frequency of CPPD crystals as well as basic calcium phosphate crystals in synovial fluid from patients that are undergoing knee replacement surgery. The studies were done probably 15 years apart and 2 different centers and with slightly different methodology, but they found this very consistent subgroup of patients with knee osteoarthritis that had CPPD. And I think that those kinds of things are telling us something. Interestingly, there's been a couple of studies, and this is a representative slide from one of the older ones that show this uses the Osteoarthritis Initiative group, all with knee osteoarthritis, that the patients with chondrocalcinosis have more pain than those with similar degrees of cartilage and bone degeneration, but without chondrocalcinosis. And the etiology of that is not known yet, but it's been shown now, I think, 3 times in relatively large studies. And the other idea which really intrigues me is that the pattern of hand OA may also be associated with CPPD. And this is an actually kind of an older concept. This paper was from 2009, but they were able to sort of identify 2 phenotypes of hand OA. One much more classic with DIP and PIP involvement, and one with MCP involvement, and particularly that second and third MCP. Not so much knee involvement and more unusual involvement of joints such as shoulders and ankles in this study. So interesting thought also that this may be a subtle form of identifying patients that are at more risk of calcium pyrophosphate deposition. I'm going to spend the next few minutes talking about associations with CPPD, because this has been really one of our strategies for looking at pathogenetic pathways. So we know that advanced age is the strongest association with CPPD. It's very unusual in patients under the age of 60. Prior joint trauma, particularly meniscal injuries, are very predictive of the development of CPPD. And if anyone is more interested in my thoughts about that, I'm happy to talk about that later. And then there are these really interesting metabolic abnormalities. So CPPD is strongly associated with hemochromatosis, iron overload, hyperparathyroidism, hypomagnesemia, hypophosphatasia, which is, congenital deficiencies of alkaline phosphatase. It's associated with gout in an interesting way. And I'm going to talk in some detail about the hereditary forms of CPPD. And interestingly, this is a fairly new disease. So described really in the early 1960s and described simultaneously in the United States by Dan McCarty as well as a Hungarian group. And the initial descriptions of CPPD included hereditary forms. So particularly in the Hungarian initial case collection, there were 5 members from a single family described. So we've known for quite a while that there is an important hereditary contribution to CPPD. Before we talk about that, there are 2 interesting new associations. And the first was rheumatoid arthritis. And we're thinking now that CPPD may be a late complication of rheumatoid arthritis. And this was an observation that Larry Ryan in our group made a couple of decades probably ago, but we published it more recently. And this is a study of a group of very well characterized seropositive classic rheumatoid arthritis patients who developed CPPD later on in their disease. And if you look at this group, mean age at the study onset was 75, more women than men, which is very typical of rheumatoid arthritis, and about a 10-year interval between the age at diagnosis of rheumatoid arthritis and the age of CPDD, or calcium pyrophosphate deposition disease, with a 13.4 mean duration of disease prior to this onset. So we found that to be very interesting, and I think you will hear more about that in other venues. The other interesting association is osteoporosis. So if you remember the patient I presented, she had really significant severe osteoporosis, which was otherwise relatively unexplained. And this was first described by Abhishek in 2014, and again, a very well characterized group of patients who had significantly lower cortical bone mineral density than patients matched for age and osteoarthritis without evidence of CPPD. And then we confirmed the osteoporosis in the VA study, which was a study of 27,000 veterans with CPPD that was fairly carefully controlled. It's a retrospective study, cross-sectional, I should say. So you always worry a little bit about overdiagnosis, but CPPD is not typically overdiagnosed. In contrary, it's probably underdiagnosed. And we found about almost a 2-fold increase in the amount of osteoporosis in patients in the VA system with CPPD. And just to refresh your memories and in terms of etiologic classification, because I want to spend the next few minutes talking about that. And I can't do it without, attributing some of my work to the people that really started this work. So this is Dan McCarty, who described this disease in 1962 and really described the clinical characteristics, the nuances, and is a brilliant man who is still doing well, and I saw him the other day. And this is Larry Ryan, who also made huge contributions, particularly to our understanding of pyrophosphate metabolism, and really dug deeply into the pathogenesis of this disease. So the only existing etiologic classification of CPPD was written by Dan and Larry, and includes the following 4 categories. So hereditary, sporadic, metabolic, and associated with trauma or surgical procedures. And I think this is important because what I'm going to talk about next is the hereditary forms of this disease and what they have told us about about pathogenesis even in sporadic cases. So as I mentioned, there are two genetic loci that have been associated with CPPD for many years, and these early studies were probably done 30 years ago with a set of mutations on chromosome 5 and a set of mutations on chromosome 8. And about now 20 years ago, I want to say, in 2000, a group of investigators found that the mutation that was responsible for CCAL2, which is on chromosome 5, is ANC. So I'm going to introduce you a little bit to ANC and what it does. So ANC is a multi-pass, very hard to study, protein that is in the membrane of cells. It's fairly widely distributed, particularly in neural tissue, but also in bone, cartilage, and other connective tissues. And it was thought initially to help transport pyrophosphate from the inside of cells to the outside of cells. And pyrophosphate is obviously a critical ingredient of calcium pyrophosphate crystals. We think that most pyrophosphate is probably made on the outside of cells, but I'm going to talk about that in a minute. And crystals are made outside of chondrocytes. This is a chondrocyte. This is the extracellular matrix. We think that pyrophosphate and calcium most likely accumulate in these small vesicles called matrix vesicles in the extracellular matrix and form crystals. And while we don't fully understand the role of calcium and over high levels of calcium in the production of crystals, we know that excess quantities of pyrophosphate are absolutely necessary for crystal formation in the normally unmineralized articular cartilage matrix. So pyrophosphate, very important in the understanding of calcium pyrophosphate disease. And as I mentioned, most extracellular pyrophosphate in cartilage originates from extracellular ATP. And this is work that Larry and I did probably 10 years ago now. And some of these enzymes, which I'm not going to go into great detail about, are very important. They're on the outside of chondrocytes, and they help in metabolizing ATP to pyrophosphate. So ANC levels, we have shown critically regulate ATP and pyrophosphate levels in chondrocyte cultures. And it was a study we published a couple of years ago where we silenced ANC. These are pig chondrocytes, and showed a significant reduction in levels of extracellular ATP. This shows successful reduction in mRNA as well as protein levels of ANC. And if you look at pyrophosphate, it's also significantly lower in patients that are in the cells, not patients, but cells in which ANC is silenced. So we think that ANC has a logical and important role in calcium pyrophosphate crystal formation in cartilage. But ANC doesn't tell the whole story, and actually ATP and pyrophosphate don't explain the whole story, and this has been a real frustration to me, and I'm going to tell you in the next couple of slides sort of where we went based on this data. So obviously ANC mutations don't explain the other major loci in familial CPPD, which is on 8q, a whole different chromosome. And historically, just to reiterate, the major focus of the pathogenic studies of CPPD has been on pyrophosphate and articular cartilage. Yet there were several metabolic disease associations that we could not link to CPPD either through what they are known to do to cartilage or their effects on pyrophosphate. And these were particularly troublesome for hemochromatosis and hyperparathyroidism. We know that hypophosphatasia, in which there's reduced levels of alkaline phosphatase, logically links to CPPD because alkaline phosphatase aids in the pyrophosphate degradation processes. And if there are very low levels of alkaline phosphatase, pyrophosphate could accumulate in cartilage and cause calcium pyrophosphate deposition. Similarly, hypomagnesemia, again, this is more theory than actual evidence, but magnesium is an important cofactor for a lot of the enzymes involved in pyrophosphate metabolism. So these kind of we could fit into the big picture. But hemochromatosis, iron doesn't really affect cartilage. We couldn't have, when we add iron, we couldn't find any effects on pyrophosphate, on ATP, on any of the metabolizing enzymes. And similarly, hyperparathyroidism was not really well linked at all etiologically to CPPD. So in 2015, a group from the Netherlands described a mutation in TNF RSF11B, which encodes for osteoprotegrin, and noticed that there was a family in which they developed severe premature osteoarthritis complicated by chondrocalcinosis. And we read this with great interest. And the next few slides, I'm going to tell you, I think, what is an exciting new development in understanding the pathogenesis of this disease. But first, osteoprotegrin, for those of you that don't think about this on a daily basis, osteoprotegrin is critical in normal bone remodeling. It's a soluble factor. It binds to rank L, and the rank L rank system really modulates the connection between osteoblasts and osteoclast formation. So it's a very critical soluble protein and important for the bone remodeling that goes on all the time in bone. This is what the protein looks like. It has a couple of cysteine-rich domains. It has 2 death domain regions, and our mutation was noted to be near the heparin binding site very near the stop codon. So it resulted in a lengthening of the C-terminal tail. We had gone back. I work very closely with Charlene Williams, who actually lives in New Jersey, so that's good. And she has been a major she's a major contributor to our understanding of ANK and ANK in hereditary CPPD. And she and I went back. She had sort of a library of families that did not have ANK mutations but had familial CPPD. And we found 2 other families that were identical to had the mutation identical to the initial description. Actually, 3 other families that had the identical mutation as described by the Ramos group. And we described the clinical picture of the phenotype of these patients, I should say, in a little bit more detail. Autosomal dominant inheritance, they had diffuse premature joint damage with simultaneous onset of exuberant CPPD crystal deposition. They had no evidence of osteomalacia on X-ray, because this was initially described as potentially a gain of function mutation in osteoprotegrin, and a lot of clinical similarity to sporadic CPPD. So we then showed, and I'm not going to go over this in great detail, but we looked very hard with the mutant protein as well as the normal OPG protein to look for any evidence that it had, number 1, it had an effect on articular cartilage, and number 2, affected either ATP production, pyrophosphate production, or the development of crystals in vitro, because we have some very nice crystal assays that we can do in vitro. And neither the normal protein nor the mutant protein affected anything. We then went back and wondered if the original report was correct and whether OPG, the mutation that we're seeing, might be a loss of function. And we very clearly demonstrated that similar quantities of the mutant compared to the wild type were much less effective at suppressing osteoclastogenesis than compared to the wild type. So that suggested very strongly that the OPG mutation associated with CPPD is a loss of function mutation. And loss of function mutations in OPG cause increased osteoclastogenesis. And going back and thinking about the other diseases in terms of not only osteoarthritis, which I'm going to talk about in a minute, but the iron association and the parathyroid hormone association. All of these syndromes have in common some osteoporosis, some diffuse osteoporosis, and very aggressive osteoclastogenesis. Iron stimulates osteoclastogenesis, parathyroid hormone stimulates osteoclastogenesis, and there's a very important role, as illustrated in this slide, for excess osteoclastogenesis as a very early factor in the development of osteoarthritis. So we were really excited by the thought that I'm going to skip this, that a loss of function in osteoprotegrin may cause increased osteoclastogenesis, that this may be exaggerated at the cartilage bone junction. And this is still a little bit of a pathway that we are working on in terms of why these excess osteoclasts increase pyrophosphate, but we've got some exciting new data in that area. And then this results in a phenotype where there is very severe osteoarthritis, cartilage develops chondrocalcinosis, and there is I think the phenotype of hereditary CPPD. So we have some data suggesting that if you put osteoclast conditioned media onto chondrocytes, they make more pyrophosphate than undifferentiated precursors of osteoclasts. And also some very exciting data about pyrophosphate as a potential mediator of some of this cycle of osteoclastogenesis that may occur and may focus the damage on the joint rather than on the bone. So in this study, we added increasing amounts of pyrophosphate to pre-osteoblasts, looked at rank ligand as a really important regulator of osteoclast formation, and found that increasing amounts of pyrophosphate stimulated the development of rank ligand on these osteoblasts, and osteoblasts that carry rank ligand increase the amount of osteoclasts in the system in which they are in. So thinking about some of the associations in this context that it may not all be cartilage and it may not be a primary disease of pyrophosphate, that those actually may be secondary effects, is sort of a new way of thinking about this disease. I think that some of the associations and some of what we know about CPPD pathogenesis do fall under the cartilage pyrophosphate category. So ANK mutations, hypophosphatasia, and hypomagnesemia, as I mentioned. And then I think there's an even more interesting group of associations that may fall under this disordered bone remodeling model, where bone is the actual first target of the abnormality. So certainly osteoprotegrin mutations, but also hyperparathyroidism, hemochromatosis. I think this is likely a cause of sporadic or age-related CPPD, because osteoclasts increase with age, and that may be some of the explanations for age-related osteoporosis. Injury and surgery certainly can stimulate osteoclastogenesis, a very important correlation with osteoarthritis. And rheumatoid arthritis, we know how important osteoclasts are in that disease. So I want to just spend the next 2 seconds, or 2 seconds should do it, talking about management of CPPD crystal arthritis, because this is where we all struggle. I'm going to review these relatively quickly. Please ask questions. I will try to answer them. But this is where most clinicians are really struggling, as I said, with these patients. What do we do with them? We diagnose them and then we can't treat them. How frustrating is that? And we do a pretty good job with acute CPP, crystal arthritis, because we treat it just like we treat gout. Intra-articular steroids, I've asterisked the treatments that have any evidence to support them. So there actually is some evidence that you can shorten attacks of pseudo gout with intra-articular steroids. We use a lot of it. It seems effective, and in very elderly patients, it eliminates some of the toxicities of systemic therapies. Colchicine works. We don't know how well. Some people think it works great. It's very variable. And the treatment regimen that we use for gout now, with the 2 followed by the 1 hour later, is probably not ideal for CPPD. So that is going to require some work. NSAIDs do work if your patient can tolerate them. Systemic corticosteroids, I think we all end up using way more of those than we want to. And there is some evidence, largely in case reports, that anakinra and other IL-1 beta inhibitors may be very useful in the acute setting as well as the chronic setting. So chronic CPPD, even worse, and I treat it similarly with or without acute attacks. Colchicine helps some patients. They need to take it regularly, but sometimes it reduces pain, and some patients find that it reduces the frequency of their acute attacks of inflammation. NSAIDs, again, a population that often don't tolerate them well. Intra-articular corticosteroids, if they have joints that are amenable to injections. We end up using systemic corticosteroids quite a bit, or I do, because they don't respond to anything else. I have had some luck with IL-beta antagonists, like anakinra, sometimes hard to get from insurance companies, and I will often call these patients seronegative rheumatoid arthritis in order to get drugs. TNF inhibitors, there actually is a couple of case reports about their efficacy. I've never tried that. Methotrexate, there is a clinical trial. It was very disappointing, but there were some major flaws in that trial, and I do use methotrexate for patients. Hydroxychloroquine, I've had some good luck with. Again, no studies. Magnesium, I don't use unless someone is frankly hypomagnesiemic. We're really good in rheumatology at using medication mixtures, so I use those liberally. A little of this, a little colchicine, a little prednisone, a little methotrexate, and sometimes that helps. And lastly, joint replacement. There have been a couple of papers recently looking at large groups of patients with and without chondrocalcinosis, and their outcome seems identical. So no reason not to use joint replacement. In conclusion, I left a lot of time for questions. CPPD is common. You need to look for it. You need to look carefully for it, and it is costly. There is some progress in improving crystal identification, so I'm excited about some of these new modalities of identifying crystals, which I think will give us much more information about the prevalence and epidemiology of this disease. We really need classification criteria schemes as not only the first step towards clinical trials, but to make sure that we're all talking about the same kinds of clinical phenotypes. And I'm very excited about the possibility of that going forward relatively quickly. And you obviously cannot do clinical trials until you can define a group of patients that you think are relatively homogeneous. And lastly, I'm very excited. I have spent most of my work on the pathogenesis of this disease, but I think these new developments in sort of understanding and bringing in additional targets for therapy really will help us develop some effective therapies at some juncture. So I am happy to take questions.
Thank you, Anne. This is Vivian. Thank you so much for a great lecture. I'm gonna just start the questions by asking, which do you think comes first in the setting, say, of the knee or the wrist? The osteoarthritis or the CPPD, or which do you think comes first, and why are they together?
That's a really good question, Vivian. One that I have thought about a lot. So I think there's actually two different scenarios. For example, in patients with hereditary CPPD due to ANK mutations, they get chondrocalcinosis first in relatively pristine looking joints. And I think this alters the biomechanics of the cartilage, which is obviously critically important to joint health, and accelerates osteoarthritis. Whereas I think in most sporadic cases, and I use sporadic sort of interchangeably with age-related, there is almost a simultaneous onset of osteoarthritis and chondrocalcinosis. Now, you probably don't see it for a while because it takes a while to get a critical enough amount of CPPD to be able to see it on a radiograph. But I think that those are very osteoclast heavy joints. You know, there's a lot of bone remodeling going on. That bone remodeling, for some reason, is leaching factors into the cartilage, which is causing excess pyrophosphate in addition to cartilage damage. And then you get sort of a cycle of destruction that is very difficult to interfere with. So I think there's actually two pathogenic pathways. And we certainly have, you know, with using hereditary CPPD as sort of a prototype, it's their disease pattern is very different in the ANK than it is in the OPGs. So I think there's two different ways of getting to the same place.
Okay, so this is a segue into the next question. What is your interpretation when we find rare extracellular CPPD in synovial fluids? If we have a patient with osteoarthritis, and we do a synovial anarthrocentesis and we find CPPD, do you think this is, what are your thoughts in terms of the contribution of this in the effusion of that patient?
I think it defines a subset of OA that we probably should be calling CPPD, because I think these patients are different than 80% of patients with knee OA. So I find them highly significant. Now, I'm also highly biased, but and it's one of the challenges of the disease. Sort of, when do you ignore it, and when do you think it's important? When would you maybe try a trial of colchicine in those OA, symptomatic OAs with a couple of CPPD crystals? I think you'd have to look at the big picture, but I don't ever ignore them, and I know that I'm not a good example of the average rheumatologist, but I think they're always important because I think they're always telling us something. And I think number has never really been shown to be predictive of inflammation. There's been some studies showing that there's always more white cells when there's CPPD crystals present compared to when there's no CPPD crystals present. So I think they're telling us something. There may be a little bit more low-grade inflammation. We really don't understand the pain pathways yet. People have looked at synovitis, they've looked at bone marrow edema. Neither of them correlate very well in the big OA study groups where they've looked at chondrocal, but I think they're important, and I think we should never ignore them.
Okay, so in essence, you're saying that if CPPD crystals are there, that it may contribute to inflammation and that may contribute to worsening OA. So to treat that would be important.
Yes.
Okay.
I'm saying that. Although, you know, we don't have great treatments, so you'd basically be suppressing inflammation. And I'm not sure it's all inflammation. I think, you know, CBD crystals, as I mentioned, do all sorts of other things and principally really alter the biomechanics of cartilage. So if you have a big block of calcified tissue in the middle of your squishy articular cartilage, you can't help but have sequelae of that in terms of major negative biomechanical issues.
Okay. Next question. Was the level of K2 checked in patients with CPPD and vascular calcification with osteoporosis?
I presume you're talking about the Abhishek, the vascular calcification. No, he did not look at K2. So,
okay.
And that was a cross-sectional study in the UK. So I'm not sure
Okay.
what else he looked at in terms of that.
Next question. What is the most common disease association? Does treating the underlying disease resolve the CPPD, like hemochromatosis or hyperparathyroidism for that matter?
No, and that's the totally fascinating thing about most of these disease associations. Well, the most common one is age, which is not really a disease, but it feels like that some days. The dogma is that that improving your hemochromatosis, for example, with repeated phlebotomies has virtually no effect on the arthritis that you get with hemochromatosis. And similarly, acute attacks of pseudogout after hyperparathyroidectomies are very, very well described. So, you know, I think there's a couple of thoughts about treating the underlying disease. I think a lot of people think that probably the crystals themselves are very hard to dissolve once they're there, so that you may have years of these crystals sort of being mined and released into the synovial fluid for both of those diseases. And also, hemochromatosis arthritis is super fascinating to me. I mean, it's a kind of combination of all the things that we see in CPPD with or without CPPD, because they have, I think, pain out of proportion sometimes to the amount of arthritis they have. They have osteoporosis, there's no question about that. And they have the identical distribution of joints that you see in age-related CPPD. So there's something fascinating about iron, and I think it also deposits in long-lasting tissues like cartilage and bone without us fully understanding. You know, phlebotomy gets rid of the circulating amount of iron, but how much is actually embedded in tissues? So that was a very long answer to a very short question.
Thank you. Next question. Since rankle-driven osteoclast activation is so important, would denosumab be useful?
I don't know. I think that's a really fascinating question, and we certainly have thought about it. So I think some preclinical studies, perhaps in a animal model, might tell us that. Also, another challenge with this disease is a preclinical model with animals. So mouse cartilage, which is all very cellular, doesn't have a lot of matrix, and may have more alkaline phosphatase than larger animal cartilage, has been really difficult to use. So I don't know the answer to that, but certainly would be a very, very interesting study.
Okay, a couple more questions. Our speaker earlier today, Dr. Loser, I mispronounced this name all morning, I'm sorry. Would CPPD subset of OA be more likely to respond to bisphosphonates?
That's a very good question. I don't know. I mean, the bisphosphonate story in osteoarthritis is kind of, I would say, inconsistent. And, you know, I think of bisphosphonates in two sort of different spheres. Bisphosphonates obviously are good in terms of osteoporosis, but they also are analogs of pyrophosphate. And so, you know, I think it would be very hard to know whether that would be a good thing or a bad thing. And I'm baffled by that a bit. They're really interesting analogs of pyrophosphate too, because they're metabolized very differently inside the cell, but they have some external effects that may be similar. So very hard to know, very complicated drugs. Can't answer that easily.
Someone wanted to know what you do with the patient case that you presented.
I think she probably has some CBPD. We ended up starting her on some colchicine. She ended up still needing narcotics to manage pain, but she did a little bit better on the colchicine than she had done on the methotrexate.
Okay, question, is there an association of CPPD with thyroid disease? And if you think so, what is the possible mechanism?
As far as I know, there is no association with thyroid disease, at least in the epidemiologic studies that we have done to date. So I don't, parathyroid certainly, but not thyroid.
Okay. Last question. What is your best way to differentiate seronegative RA versus CPPD when no crystals are present?
That's a great question. So I look at the patient. You know, if the patient is 30, I think this is much more likely to be seronegative RA than it would be CPPD. So the demographics of the patient. I look at the distribution of joint involvement. So CPPD, second and third MCPs, often, you know, joints that are not typically involved in rheumatoid arthritis, like DIPs. They have odd disease, you know, that doesn't look like typical rheumatoid arthritis. So, I mean, those are the kinds of things that I use, and I will, you know, always, all of us, I know, constantly reevaluate when we see patients. Is this the right diagnosis? So any opportunity to get some synovial fluid you don't want to waste that.
Thank you so much, and we appreciate your lecture. It was excellent. Thank you so much for coming and talking to us.
All right. Very happy to be here or there or wherever I am.
Take care.
Bye-bye.
Bye. Okay, I think, I don't know if you want to take a little bit of a break, everybody, or maybe we can just get going with our last speaker for the morning, Dr. Haj Ali, are you here? I thought I saw your name earlier, but don't know if she's here. Oh, she's here. Rula, are you here?
She's unmuted.
She's unmuted.
There
Hi.
she is.
Hi. Hi, everybody.
Hi, welcome.
There we
welcome
go. Good.
To our meeting. I'm just going to talk a little bit. I'm going to go over a little bit about, just to introduce Dr. Haj Ali. She's going to summarize CNS vasculitis and its imposters today. She's professor of medicine and staff physician at the Center for Vasculitis Care and Research at the Cleveland Clinic, board certified in internal medicine and rheumatology. And she graduated from American University of Beirut Medical School in Lebanon, performed internal medicine training at Strong Memorial Hospital in Rochester, New York, and the Cleveland Clinic, and did a fellowship at the Cleveland Clinic. And she's been there since 2002, currently holding the academic rank of professor of medicine. She has an interest in systemic inflammatory diseases, vascular inflammatory diseases affecting, including systemic vasculitis, CNS vasculitis, and inflammatory eye disease. She is the director of the multidisciplinary CNS vasculitis clinic, which is highly qualified multidisciplinary clinic evaluating and treating patients with CNS vasculitis, which is a tremendously challenging disease. She holds an AOA Alpha Omega Alpha honor and was elected America's top physician and received the Clinical Society of Rheumatology Best Fellow Award and Clinical Research Award from the American Heart Association, as well as Teacher of the Year Award in recognition for excellence and dedication to education of fellows, residents, and medical students. She has presented her research findings in many national and international scientific meetings. Her work in CNS vasculitis has been published in leading professional and scientific journals. She's the author of multiple chapters in major textbooks on the topic of CNS vasculitis. So thank you so much, Dr. Haja Ali.
Oh, thank you for inviting me, and I hope everybody is doing well with all what's going on. Can you see my slides?
Yes, yes.
Okay, and obviously you can hear me well, right?
Yes, we can hear you.
Perfect. Okay. So what I would like to go over today is, definition of what is CNS vasculitis. In general, what do we see as rheumatologists? And we're gonna go over the approach of these patients when we see them as rheumatologists, and then go over a few, cases that just to demonstrate some points, and then wrap up with treatment outcome. Just to give you a definition, CNS vasculitis can be primary or secondary. The first report of CNS vasculitis were recognized as a granulomatous meningitis of the CNS. This is why you see in the old literature the term GACNS, which is granulomatous meningitis. Then you have the PACNS, which is primary, and then you have CNS vasculitis. And this can be primary or secondary. Primary, if it's only affecting the brain or the spinal cord. So you can have vasculitis in the brain and or the spinal cord only, without any other systemic involvement at all. And this is where we refer to it as primary. And it is secondary if it is secondary to other processes, whether it is an inflammatory process such as systemic vasculitis or infection or other inflammatory diseases, or even infectious diseases. It's a rare disorder, but it is better recognized right now. And I think, what we as rheumatologists have been called more often to rule out CNS vasculitis in the past few years, and that's because the readily availability of different vascular images. Everybody comes in with some neurologic symptoms, they get an MRI, but they also, get the threshold to get an MRA and a vascular images is really very low. And then there's some abnormality that comes up on the MRA, and most often we as rheumatologists get called because there's an abnormality on the vascular images of the brain in a patient who is young to have other reason for abnormal vessels of the brain. There's no reasons to get atherosclerosis or not. So whether you like to see these patients or not, it's really a question that is coming up very often. And the diagnosis is not as often as the process of going through these patients. It is challenging to really go over these patients, and there are multiple different challenges that we go along with this. There is the rarity of the disease. There is no specific symptoms, as we get to go see later on. In my presentation, there is no specific serology or blood test that tells me that this is CNS vasculitis. And even, sometimes we are shy to do a biopsies of the brain, and we will go over this. So this is a really challenging disease. In primary CNS vasculitis, your blood test is normal. Your SED rate, your CRP, your serology, they're all normal, all negative. You do these testing to rule out other conditions. But you can have brain vasculitis with a normal SED rate and a CRP if it is primary. And the more we study this entity, the more we know it is a heterogeneous entity. It is not only one disease. We see it at the pathologic level. We do have different pathologic manifestations. Some are granulomatous, some are lymphocytic, different presentation. We have large vessel involvement of the brain. We have small vessel involvement of the brain. So it's a more heterogeneous disease, and it's not a homogeneous disease. As you are all familiar with this diagram, as we like to classify patients according to vessel wall size because of their distinct clinical phenotype. Where does CNS vasculitis fit in? And I'm talking about the primary CNS vasculitis. It fits in the isolated organ vasculitis. There are or isolated vasculitic syndrome where there is only vasculitis in that organ. In a primary CNS vasculitis is there where it fits in. Secondary CNS vasculitis can be to many of these other syndromes, and I'll talk about these in a little bit. So in systemic disease, in ANCA-associated vasculitis, CNS can be involved. In GPA in particularly, it's a rare manifestation, and the estimate prevalent incidence is about 7 to 11% of GPA patients. There is usually 3 histologic patterns. Either a small vessel vasculitis of the brain or the spinal cord, or you have contiguous invasion of granuloma from your sinus tissue all the way down to the brain. And sometimes you see isolated intracranial granulomatous lesion. We see it mainly in the hypophyseal area. So if you see granulomas in the hypophyseal area, pituitary, with somebody who has systemic disease, think about GPA. The other differential diagnosis is sarcoidosis. This is a French study that looked at CNS involvement in GPA. The most common symptoms are headaches. There's also sensory and motor impairment. But I want to draw your attention to pachymeningitis, which occurs in 57% of these patients. So when you see patients with pachymeningitis in general, you have to rule out GPA, and I usually do ANCA on all these patients with pachymeningitis. Cerebral ischemia occur about 43%, and hemorrhagic lesions are less common. In general, hemorrhagic lesions are not common in CNS vasculitis. Systemic lesions are more common than hemorrhagic lesions. And as I said, hypophyseal involvement occur in around 6% of the patients. And patients with GPA can relapse in the brain with only hypophyseal involvement without any other involvement. So keep that in mind. In EGPA, which you all know about what is EGPA, I'm not going to go over this. CNS involvement can rarely occur and occur in about 1 to 8% of the cases. And here you see more hemorrhages than other vascular disease. In Behçet syndrome, neurologic involvement occurs in less than 10% of the cases, more frequently in men than women. It usually occurs a few years after the onset of other systemic features. Neurologic diseases can be parenchymal or non-parenchymal. The parenchymal diseases mainly affect the brainstem, or it can be multifocal disease, and they can present as encephalopathy, hemiparesis, seizures, dysphagia, mental changes, and optic neuropathy. If you look at the reported pathologic findings in neuroBehçet, what you see mainly is a local periveneal lymphocytic count scuffing and cellular infiltration and necrosis. The non-parenchymal disease in Behçet syndrome can affect the venous as well as the arterial side. And just to remind you, Behçet is a vasculitic syndrome that affect any vessel size and affect the venous and the arterial side. So here we see that the same in the brain. It can cause cerebral venous thrombosis. Patients usually present with severe headaches, intracranial hypertension. It can cause acute pterygial syndrome, and commonly stroke, dissection, or aneurysm. Giant cell arteritis stroke is uncommon in general. And GCA is a very, very rare cause of stroke. And if it happens, usually it's because of extension of a large vessel vasculitis and mainly affecting the vertebrobasilar artery distribution. Intracranial vessel involvement is extremely rare in GCA, and strokes usually is correlated with ophthalmic ischemia. In Takayasu arteritis, the prevalence of stroke is about 15.8%. However, scarce information on the type of the stroke here. Stroke as a manifestation of Takayasu arteritis is rare. However, if you are consulted on a young female with stroke, you have to make sure you check all the pulses and check a extensive vascular physical exam, including Bruise, because Takayasu can present this way. Well, we have seen in our institution, and that's, we also have a referral bias, is that we have seen some patients with CVID that can present as CNS vasculitis. And we have looked at the literature and we found other 15 patients. So we put this manuscript together to draw attention that CVID can actually cause CNS vasculitis. And this is a literature review in addition to our cases. What we found in about most of these patients are female and Caucasian, and they have granuloma in other organs as well. And patients present with mostly brain masses, so they have these masses in the brain, and they can be recurrent. And the brain pathology could be granulomatous or lymphocytic infiltration, and it is angiocentric around the vessels or invading the vessels. And your CSF is usually inflammatory. This is one of my patients who had CVID, and you see here a very nice vessel, and here you see a distracted vessel with multiple granuloma on higher field. Another entity that we have heard a lot about it in the past few years is ADA2 deficiency, which also can cause stroke in young adults, and keep that in mind. Just to refresh your memory about it, so the deficiency of adenosine deaminase 2 is an autosomal recessive disease caused by mutation of that ADA2. There's clinical manifestation include fever, proteinuria, hypertension, peripheral neuropathy, immunodeficiency, livedo reticularis, red cell aplasia, and neutropenia. But some people, these systematic presentation and manifestation can be very subtle, and a patient can just present with stroke, and they can also present early, in early adulthood with stroke, and it may not be just in childhood. So keep an eye on this when you see young patients with stroke, and if they have other manifestations as well. So it's important to really recognize this, because we have seen that the treatment is different. We've seen a better response with NGTNF in reducing stroke in these patients. How about in other diseases, in our diseases? SLE, we have CNS manifestation, and involvement in SLE is rarely vasculitic in nature. Less than 2% of patients with SLE have CNS vasculitis. Encephalitis and CNS involvement is different than vasculitis. If you look at the autopsies of patients with lupus, most what you see on the autopsy, not really vasculitis. It's like a healed vasculopathy, not really vasculitis. It's more like a hypertensive vasculopathy. You can see CNS vasculitis in sarcoidosis, but it is extremely rare, as well as in mixed connective tissue disease and Sjogren's syndrome. You have to make sure that this is not infection, and any infection can cause CNS vasculitis, whether it is viral, bacterial, fungal. And this is the main challenge in these patients, is to really rule out infectious causes, especially when your CSF is inflammatory. And I will talk about that later on. So how do we diagnose patients with CNS vasculitis? There has actually been criteria that were published by Len Calabrese in 1998. Although these criteria were old and were never validated at a larger base, but these criteria remain the basis of how we approach and diagnose patients with CNS vasculitis. What these criteria tell us, to make a diagnosis of CNS vasculitis, you have to have a neurologic deficit unexplained after vigorous diagnostic workup, and either indirectly vascular involvement when you have an angiogram abnormality or an MRA or CTA abnormality, or a biopsy evidence or vasculitis within the CNS. So you prove that you have vascular involvement here. But the most important is exclusion of all conditions capable of producing secondary arteritis or mimicking the angiographic feature of arteritis. So what are the exclusions? It's a very big, challenging task to do. And you as rheumatologists are very good in ruling out systemic inflammatory disease. So I'm not going to go over this. You know, the other challenging for us is ruling out the others. So this is a multidisciplinary approach. You really have to have your stroke neurologist with you, helping you in, from ruling out things from their perspective. When you see strokes, especially in young patients, this still could be premature atherosclerosis. It still could be other embolic things. It could be in a little bit elderly patient, could be embolic with atrial fibrillation. Hypercoagulability disorder is really important to rule out. And recently I have seen a patient who have atypical HUS who presented with multiple stroke. And as we diagnose atypical HUS more commonly now, keep that in mind as a cause of stroke in the young. Infection, I cannot stress how much is important to rule out infection in these patients. And this is really important because your treatment is totally different, and infection can cause vasculitis. We all know that VZV invades the vessel and stays in the vessel and can cause strokes and can look exactly as a granulomatous inflammation in the brain, and it can mimic CNS vasculitis. So having said that, a very thorough review of system and about the immune status of the patient, travels, exposures, all these are important, and including your infectious disease specialist as well. And I'll talk about other new modalities in ruling out infection in the CSF. This is the miscellaneous group that we call them the zebras, but you see them, and we see them as when we make a diagnosis, usually when patients come in for second opinion because they're not getting better or remain to have problems after they're being treated with CNS vasculitis. So you have to rule out other things that can mimic CNS vasculitis. And I keep in mind things such as genetic abnormalities, and I'll give you some examples on one of the cases that we have seen. Other miscellaneous disorders are Sussex syndromes as well. So this is an autoimmune endotheliopathy that affects young women with encephalitis-like pictures. They also have hearing loss. They also have retinal artery occlusions and retinal vasculitis. So when you see, these patients always get a thorough eye exam with fluorescent angiogram, because the patient may not have the visual symptoms can be attributed to central causes in the brain, but it could be actually the diagnosis can make by just fluorescent angiogram of the eye. So how do I approach patients with CNS vasculitis? I follow 7 heuristic that I follow to really make sure I go systematically one by one, and I will share this with you. Number 1, there is no specific clinical findings or set of findings of sufficient pretest probability to secure diagnosis of PACNS. If you look at the Mayo Clinic series of CNS vasculitis, which was the larger, look at the clinical manifestation all over the place. So according to the symptoms, I cannot really tell by symptoms if this patient has CNS vasculitis or not. But headaches are very common. So headache plus neurologic deficit, that's usually the presentation of CNS vasculitis. But the characteristic of headaches, and really this is important, is that your headache is chronic insidious. It's not what we call thunderclap headache. It's not the worst headache in your life. It comes and goes, just a chronic headache. It doesn't come like this, insidious and very fast. But the highest pretest probability is when you have chronic meningitis, like picture recurrent focal deficit and unexplained focal and diffuse neurologic deficit. So how the history helps me? Helps me, what I do is I go over review of system, as all of you and you as rheumatologists are very good in doing this. So basically, I want to rule out systemic diseases first. Look for sinus diseases that rule out GPA or sarcoidosis, hearing loss for sarcoidosis, as well as SUSAC, inflammatory eye disease. It really helps me in finding out other systemic diseases in sarcoidosis, as well as in GPA, eGPA, relapsing polychondritis. Ask for orogenital ulcers for Behçet syndrome. Ask for any asthma-like symptoms or shortness of breath, peripheral neuropathy, and then look for other symptoms for hypercoagulable diseases such as antiphospholipid syndrome. Look for levodoreticularis. Ask for Raynaud's. There are some patients who present with Raynaud's and stroke, and this is an entity that we refer to as Sneddon syndrome. So look at these subtle things: kidney issue, urine analysis, previous history of DVT, miscarriages. So we all know how to do that as rheumatologists, but I always remind myself about 2 things. I remind myself about asking about family history of a neurologic disease. That will help me to rule out genetic causes. If the patient's family is known to have a genetic disease, they're already diagnosed, they will not come to you. So the way I ask about this is that, has anybody had any stroke at a young age? Has anybody had MS or tumor or any neurologic symptoms, or any patient died or any relative died at a younger age? And I also remind myself to always ask the patient about exposure histories, any medication that they take over the counter, or any medication that they take to suppress the immune system. So these 2 things is just a reminder every time when I see these patients. Heuristic number 2, lumbar puncture, is extremely important. Your workup for CNS vasculitis is incomplete if you don't have a CSF study. Your CSF has only been omitted if there are a contraindication to do it. What you learn from the CSF is really important. You look at the white count, you look at the protein, you look at the cultures. So in CNS vasculitis, you have an inflammatory pattern with high white count, high protein. When your CSF is normal, it makes me less think that this is CNS vasculitis, although there are some cases, very rarely, they can be this way if the CSF is early on. And if you have large vessel vasculitis, which is at the base of the brain, sometimes your CSF is not really highly abnormal. So when you see an inflammatory process of the CSF, it makes you more think this is CNS vasculitis. Although this is not very specific, but it does help you. So infection can cause an inflammatory process as well. And you really have to make sure to rule out infections and workup of infection depending on the exposures of the patient. If the patient has never been traveling anywhere else, is different than the patient who has traveled to South America, where you have more cysticercosis. So I'm not going to check cysticercosis as someone who has not traveled over there. So you have to tailor your workup. But in general, what do I do? What do I do with my CSF other than the regular culture? I also check for VTB. I'll check for Lyme. So anything that causes chronic meningitis-like picture, HSV. These are the things that I check. And I also check next generation sequence on these patients, and I'll talk about that in a little bit. How about non-vascular neuroimaging, what I'm referring to as MRIs and the CT? These are very highly sensitive, and especially the MRI. The CT is not as sensitive as the MRI. I've never seen any patient with CNS vasculitis with normal MRI. You have to have an abnormal MRI to have CNS vasculitis. So it is very sensitive, but is not specific. What you usually see is multiple ischemic lesion in different areas. Some are old, some are new, and in different areas. Rarely you see hemorrhage, and you see gadolinium-enhancing lesion, whether in the meninges as well as in the parenchyma. And the test choice is an MRI, not an MRA, not a CT. This is some example of MRI of patients where you see different infarct here. And this one, you could see the enhancement in the leptomeningeus and the cortex as well. This is a angiogram that see smooth tapering of the vessel. See how this diameter here differ than this one. Another presentation on the MRI could be mass-like lesion, and about 5% of these patients have mass-like lesions. Look at this one. And usually when you have mass-like lesion, the small vessels are involved, and your vascular study is going to be normal. So your MRA, your CTA, even your angiogram will be normal, because this is the small vessels that are affected are beyond the resolution of an angiogram, and you're not going to be detected. On an angiogram. So remember, MRA is for larger vessels, then the CTA gets better resolution, and the best resolution is by angiogram. But still, by angiogram, you cannot detect smaller changes with these small capillaries, and that's what you see here in mass-like lesions. And this is only can be diagnosed by pathology. Most of these patients are mistaken to have malignancies. How about vascular images, direct or indirect? When I mean by direct, this means our conventional angiogram, and indirect is MRA or CTA. There is no angiographic study of 100% of specificity for the diagnosis of CNS vasculitis. So keep that in mind. It's not specific at all, even if your neuroradiologist is going to convince you this is CNS vasculitis. Keep in mind that this could be something else, but because your vascular images are not very specific, even if you see the typical finding, what you see is multiple area of stenosis and ectasia, and what we call them beading, is not really specific. Specificity of angiogram is as low as 26% of the cases. This is some example of an angiogram. We see here, you see this beading, like you see this is dilatation, narrowing here. This is some narrowing here and dilatation as well there. I don't know if you could see that. Also some narrowing here, diffuse all over, what you could see over here too. This one here, you see this vessel has this narrow, so multiple area of different irregularities in the vessel bed. This is a patient who have, you see this severe stenosis here of the basilar artery, and he has a cut off of the vertebral artery, which was totally occluded. This patient has vasculitis, but it turned to be syphilis-related CNS vasculitis. Look at this angiogram. This cannot be better than what you look as bleeding. Multiple area of stenosis in dilatation. This is not CNS vasculitis. Look at this one here. Look at this segment over here. This is RCVS, which is reversible cerebral vasoconstriction syndrome. This is an entity that was put a name for it in 2007. And it is not a vasculitis, it's a vasospasm in the brain. So these are all vasospasms. It presents as acute thunderclap headache, the worst headache in your life, and it's acute like this. You would be sitting, most of the patients would tell me when they develop the headaches because they know exactly, when this happened because the headache is severe. They've never had it, in their life. And most of these patients go to the emergency room to rule out any intracranial hemorrhage or subarachnoid hemorrhages. And what you see is this diffuse pattern of abnormality in both hemisphere and multiple area. You cannot have RCBS in one segment. It's multiple segments in the brain. You have to rule out aneurysmal subarachnoid hemorrhage. When you look at the CSF of this patient, it's totally normal. It's a spasm. It's not a vasculitis. But you can have strokes. You can have hemorrhages. You can have very highly abnormal angiogram. But your CSF is normal. See how the CSF is really helpful here. And your pattern of headaches here is really important. If you have a hemorrhage in the brain, your CSF could be, abnormal slightly because of the hemorrhage. But if you don't have hemorrhage, your CSF should be normal. And the diagnosis was usually confirmed after resolution. So in a few weeks, this vascular abnormality resolve in an average of 8 to 12 weeks. But when patients come in acutely, how do you differentiate between both, whether this is CNS vasculitis or RCVS? As I said, the headache feature is really important. Here it is thunderclap. This is insidious. CSF is normal. In CNS vasculitis, the CSF is abnormal. And remember, I told you I've never seen MRI, normal MRI in CNS vasculitis. Here in RCVS, patients can have a normal MRI. They can present with the worst headache in their life. They get an MRI. The MRI is normal. But because of the persistent headache, they come back and forth to the ER with the worst headache. They can get an MRA, and the MRA could be totally abnormal. But their MRI is normal, so keep an eye. And this is a diagnosis. Everybody have an abnormal vascular images. This is the way you make the diagnosis. Here, not everybody has a abnormal vascular images. So there are multiple conditions associated with RCVS. It can be postpartum. It can be exposure to drug, as well as a product or idiopathic by itself. So what I see in my practice with RCVS is patients usually take things over the counter. This is why I ask about any medications. Patients will not tell you about over-the-counter medications because they will not put them in the category of medication. So ask about Sudafed, allergy medication that has phenylephrine, Sudafed. These are the ones that can cause spasm in the brain. And sometimes also, if patient on a high dose of SSRI can cause it, and this is the most common etiology of RCVS that we see in practice. Other illicit medication can cause it, and sometimes tacrolimus, IVIG, massive red blood transfusion. You also can see it in other conditions as well, but that's the most common. All right, so going back to differential diagnosis of abnormal angiogram. It's, as I said, it's very not specific for CNS vasculitis. You can see it's premature intracranial atherosclerosis, FMD, moya-moya disease, intravascular lymphoproliferative disorder, radiation vasculopathy, disease with cerebral multifocal thromboembolism, RCBS, and infection. So it's a huge differential diagnosis for your abnormal vascular images of the brain. How about some diagnostic advances? You heard me talking about next generation sequence on the CSF. This is not available in every center, but what does this is that you can, on the CSF, if you have a high suspicion of infection, but you're not really sure where it is, if you have a very high white count, etc., and you know your other culture has been negative, this is a test that has been developed by the UCSF lab. And what does this give you is that unbiased sequence of a biologic sample. So you take your CSF, and then they sequence all genetic material. And then they look for any pathogen on the library after they minus the host genetic sequence. So it's unbiased way to look at infection. And it is a standout test. We don't do it in-house here at the Cleveland Clinic. We actually send it to UCSF, and it is on their website. The turnover rate is about, I would say, probably a week for this to come back. It's very expensive. Insurance company usually cover it as outpatient. As an inpatient, it's a different story. It costs about $2,500 for each sample. Another diagnostic advances that we have been used that helps is sometimes surrogate marker for inflammation, but with caution with this is what we call imaging of the vessel wall. So this is the protocol of the imaging of the vessel walls. You actually null the blood and you look at the vessel wall after you give gadolinium to see whether your vessel wall enhanced or not, where there is stenotic lesions, and you look into that. This is a patient with CNS vasculitis. We see this is a stenotic vessel here. This is pre-enhancement, pre-gadolinium, and this is post-gadolinium, where you see this diffuse enhancement of the vessel wall. And what we see in this protocol, if it is CNS vasculitis, usually you see a concentric enhancement, meaning your vessel wall is enhancing all over diffusely, as opposed to patients who have atherosclerosis, when you can see sometimes some enhancement, but your enhancement is eccentric, meaning some around the plaque only, and you see usually plaque with some enhancement. This is how you differentiate. And in CNS vasculitis, your enhancements, as you see in this patient, is diffuse and also like a long segment of enhancement. But you have to be very careful with that because this is not 100% specific as well. But if I don't see enhancement, that will probably give me more reassurance that this is not inflammatory. But again, this is an MRA. This is going to pick up the medium to large vessels. The MRA is not good to look into the small vessels. So if someone has a small vessel vasculitis, your MRA is going to be totally normal, and it's not going to enhance, and you're not going to see any occlusion on your vessels at all. So this helps in the diagnosis, but it's not the only thing that you rely on. This is a patient with neuropathy, had an infarct. You see here the M1 occlusion by MRA. And let me show you a good picture here. Here you see like all the vessel is concentric enhancement of the vessel, as well as here, which is vasculitis. This is another patient. This is at the beginning of her involvement. This is CNS vasculitis, and see here how she progressed. And this is after treatment, where the enhancement actually did improve. We don't have so much data on follow-up of these patients. We are going to present some data in the ACR, but there is some signal that the enhancement will get better in these patients upon follow-up. This helps me in ruling out RTBS versus CNS vasculitis. In RTBS, your MRA is not going to enhance, although you have stenotic lesions on your MRA, but they're not going to be enhanced. But remember, this is not an inflammatory process. It is a spasm. This is a patient with vasculitis where you see the enhancement, and this is a patient with RTBS where there's no enhancements, and the two vessels, shows abnormalities and stenotic lesions. So that's helpful in RTBS as well. Remember the patient that I told you he had neurosyphilis? This is which I showed you his angiogram. The basilar artery was very stenotic. See his enhancement? It's diffuse enhancement of, and look at this concentric enhancement. This is vasculitis, but it's infectious vasculitis. So you have to be careful as well, because it can enhance. It's a vasculitis, but it's not going to tell you whether it's infectious or not. How about brain biopsy? I think brain biopsy is underutilized, but it is a very valuable tool. But we have to understand its limitation. And there's multiple reasons to biopsy to rule out if your workup has not getting you a very good assessment whether you have vasculitis or not. You have to really get a biopsy. And when you get a biopsy, always include meninges, leptomeninges, because your diagnostic yield will get better. The vessels, as they go inside the brain, they're all going to pass through the meninges. So it's a vascularized tissue, and then you get a higher yield. What are the limitations? What is a positive biopsy? True vasculitis is transmural inflammation of the brain, of the vessels in the brain. It's not perivascular inflammation. Perivascular inflammation is different than vasculitis. The brain reacts with any insult with perivascular inflammation. So you could see perivascular inflammation in CNS vasculitis, but if that's the only thing you see on the brain biopsy, it could be anything else. And if you treated somebody with CNS vasculitis based on a perivascular pathology and the patient doesn't do well, revisit your diagnosis, because you have to really see a transmural inflammation to really say this is a true vasculitis. And even if you see transmural inflammation, you have to rule out infection. You have also to rule out other, such as malignancy, lymphocytic inflammation. It could be intravascular lymphoma. Look for amyloid as well. So infection and cancer are really important to rule out in these patients. Infections, VZV, HIV, others, according, as well as we said in patients who, with exposure, but in general, everybody gets VZV, Lyme, HSV, TB testing on these patients, as well as RPR on the CSF. Make sure you are looking at pathology with your pathologist, and look if it is lymphocytic pathology, you have to rule out lymphoma. And if it's a granulomatous, make sure it's not other infectious causes. Let's go over this case. This is a patient who presented with multiple stroke. CSF was very inflammatory. Biopsy shows granulomatous angiocentric inflammation with giant cell. As you see, look at this beautiful giant cell. This is all in the vessel wall. Later on, 3 weeks, it turned out to be TB. So even if you have granulomatous inflammation, be careful. This is another case, a young patient who presented with lightheadedness, transient visual loss, and was found to have a stroke. And this is where we are consulted more often as rheumatologists, stroke in the young population. Then he came back again in July with another stroke as well. This is another area of stroke. Had post-medical history of hepatitis C untreated. He used to to use drugs, but he denied any drugs recently. And he doesn't have much family history except diabetes, high blood pressure, and father died from liver related to alcohol. And when we was admitted to our institution, first his white count was elevated on the CSF, so it was an inflammatory pattern. All the serology were negative. All infectious disease was negative as well. His PET CT did show uptake in the midbrain. We've been doing more PET CTs as well to rule out other things, in the body that could give you a hint, although it's not very specific. It is very expensive, but it could help sometimes. Nobody has looked at the data whether it is, like cost effective or the utility of it, but sometimes we use that as well. This is his images. Look at this uptake in the brain. Look at these vessels. Look at this narrowing on his angiogram. So neurosurgery did not want to biopsy him. He had a negative infectious workup. He was given a steroid trial. He felt much better. He went home on prednisone taper. He came back with a worse headache. And then his CSF had progressed with a higher white BC count. So what is this? This is infection because it got worse on steroids, and it is later on his CSF turned out to be aspergillus. How about heuristic number 7? Treatment response. Failure to respond or progress on cyclophosphamide or glucocorticoids suggests an alternative diagnosis, as the patient has just discussed. If you have committed somebody to a treatment, even if you're not sure, a lot of the time we have a possible CNS vasculitis. We cannot prove it, whether it's a biopsy or it's on an angiogram. You have ruled out everything, but then you committed the patient for the possible or working diagnosis of CNS vasculitis. If they do well, that's great. If they don't do well, revisit the diagnosis, especially if you have used cyclophosphamide, because cyclophosphamide is a very good medication for CNS vasculitis, especially if you do it, oral daily cyclophosphamide rather than IV cyclophosphamide. This is a patient who presented for second opinion, was a transfer from a hospital, was diagnosed with CNS vasculitis. Look at her biopsy, which has lymphocytic, benign looking lymphocytes in all her vessels. She was refractory to cyclophosphamide, rituximab, and IVIG. A second brain biopsy shows diffuse infiltration by large malignant cells. It was T-cell lymphoma. So she didn't respond to treatment. You have to revisit the diagnosis. It's hard to convince somebody to have a second brain biopsy. This is a patient who presented with retinal vasculitis initially, was treated with steroids, did well, then later on started having neurologic deficit and decline, mainly cognitive, and this is his MRI. His CSF showed high protein. All other serology were all negative. Infectious disease serology and cultures were all negative. And then he eventually had a brain biopsy that shows perivascular inflammation. Again, this is a perivascular inflammation, not transmural inflammation. So neurology committed him to cyclophosphamide for possible CNS vasculitis, which is reasonable at this point, and he was treated with cyclophosphamide. But despite of that, he had worsening of his MRI. So was sent to us for other treatment for CNS vasculitis. When we looked at him, we found multiple red flags. The biopsy was perivascular inflammation. He did not respond to immunosuppression, especially with cyclophosphamide. Workup was negative for infectious disease. His family history shows blindness in his dad, and he actually died early. And cousin has diagnosis of brain tumor. This patient passed away 4 years after the initial presentation. So what did he have? He had retinal vasculopathy with cerebral leukodystrophy. It's an autosomal dominant systemic small vessel disease with specific TREX1 mutation. Patient can have vascular retinopathy, starting at the age of 35 to 50 years, and then they start having neurologic deficits due to progressive enhancing cerebral white matter lesions. You can have focal or brain lesions. Other systemic manifestations, some patients can have brain nodes, very slightly abnormal kidney function tests that can be dismissed, and some patients also have very slightly abnormal liver function tests, which also can be dismissed for other reasons. So think about this. This is a TREX1 mutation. Unfortunately, the symptoms start at the later age, and patients unfortunately would already have their families, and it's a very unfortunate disease. I hope it is rare, fortunately, but it is fatal. So there is no specific clinical finding. Your lumbar puncture is very important. Your non-vascular neuroimaging are specific but not sensitive. Your vascular imaging is not very specific. Keep that in mind. Ask for brain biopsy if you're not sure what's going on. Rule out mimics, and failure to treatment should always trigger an alternative diagnosis. This is the last part, and I don't have so many slides of this because this is a rare disease. We have not had any evidence-based treatment on this. What has been reported in the literature is a mixed treatment between patients who were treated with only cyclophosphamide and steroid, or steroid only. It's a mixture of both. And if you look at the literature, there are some has looked into patients who actually received cyclophosphamide and steroids and compare them to those who did not receive cyclophosphamide, and the outcome is about the same. But I will carefully say that we cannot compare these patients together. They're different, diagnoses are different. This is a heterogeneous disease, so you cannot comment on this comparison. So how do we treat these patients? Depending on the burden of the disease. If I see somebody who is really have multiple strokes, I'm going to use cyclophosphamide in these patients, especially if I have a biopsy proven with vasculitis. And my best treatment would be daily oral cyclophosphamide. And when I use that, I use it for 6 months. I don't use it less than that. And then along with the steroid, and then maintain these patients on other immunosuppressive medications such as mycophenolate or azathioprine that penetrate the CSF better than the methotrexate, and just follow like the same as a small vessel vasculitis treatment. Treat them initially with big treatment and then maintain therapy. Has there been any role for biologic? There have been 1 or 2 cases in the literature for this. And at this point, this has to be very individualized in patients who really cannot take cyclophosphamide. I would not use anti-TNF. I'll probably use rituximab, but in a very, very selective patient. We don't have so much experience with that. Unfortunately, our treatment still remains cyclophosphamide in these patients in long-term steroids. How long do I treat these patients? In the acute phase with cyclophosphamide, 6 months. And then later on switch them to a maintenance therapy. How long I keep maintenance therapy? As long as the patient is tolerating it, because these patients can relapse. I have patients who opted to stop and they relapse, and if you relapse in the brain, is ugly. So keep these patients as long as it is tolerated, either your Imuran or mycophenolate. There have been outcome data on these patients. We've done much better than was originally described as a fatal disease, but still the mortality rate is between 17% of these cases. But most of these patients do well after the first year. So after they recover from their strokes, they do well in these patients. But depression is really high in these patients as in any stroke patients. So keep an eye on that. So I'm going to summarize. We really have done much better in understanding these disease, and that's because of all these different investigators listed here. We have done better in diagnosing and ruling out other conditions. What is really going on now in CNS vasculitis is that we have a multi-institutional effort in putting together a biobank to biobank these patients at the CSF level, blood level, imaging level, and tissue level to better understand these patients, because this cannot be done as just one effort. It's a rare disease, but it really comes up very often in the differential diagnosis. So thank you so much for listening. I'm going to stop here and take any questions.
Thank you so much, Dr. Haj Ali, for this excellent talk and a nice review. This is something we see at least 2 or 3 times a year, rule out CNS vasculitis, and we're struggling to do the workup and guide our colleagues. Let me just ask you, realistically, in your algorithm, in the evaluation of someone with CNS vasculitis, when do you actually do consider doing a brain biopsy?
So if I have a patient who I really cannot commit the diagnosis, I'm going to, look to ask my neurosurgeon to do a biopsy. And especially if you can biopsy a lesion that is amenable to biopsy. I do understand that some lesions are really risky to biopsy. But if you have to really work with your neurosurgeon, and you have to mainly if you have a neurosurgeon who mainly work with vascular neurosurgeon, will be best in dealing with these patients because they have a better outcome. I have never had any problem with any biopsies that I have asked. The issue with the biopsy when I talk to the family or the patient is that sometimes it's not going to come diagnostic, and they will commit to have a brain biopsy and to have a non-diagnostic brain biopsy. But there has been some theories that look at that. Your brain biopsy, even if it's non-diagnostic, is going to rule out some other things. It will rule out infection. It will rule out, when you look at this biopsy, especially if you culture the biopsy and you look at, you can rule out lymphoma. You can rule out other things. In the sensitivity of your biopsy is 75%. So you can still have CNS vasculitis and commit to the diagnosis, but after ruling other things.
Where would you, what area of the brain would you biopsy?
You want to biopsy around an area which is affected by the MRI. If it's not amenable to biopsy, you can go randomly to the non-dominant temporal lobe and just take a tip of the temporal lobe. But your best diagnostic yield is when you are around the biopsy, the area which is abnormal on the MRI.
And there's a question here. What is your opinion using dexamethasone over methylprednisolone for CNS penetration if you're trying to treat CNS vasculitis?
I know that the neurologists like that and the neurosurgeons, but we have seen, we have pulsed our patient, initially, but later on, we have treated our patient with just prednisone at home, and they did do well. I mean, these patients has inflammation. Your blood-brain barrier has been breached, and wherever you're gonna give them, it's going to go in.
Okay. Here's another question. Should every patient with suspected vasculitis have a brain biopsy?
If you can.
And how would you treat the patient? Is it cyclophosphamide for anybody that comes in with CNS vasculitis then? They automatically get cyclophosphamide. That's the best data we have.
If you are 100% sure of your diagnosis, yes. And then there are patients that are only treated with steroids, and that should be very individualized. Like if I am really not that convinced in a patient that they have CNS vasculitis, I may not opt to do cyclophosphamide at the beginning. So there are patients who are diagnosed, just by an MRA or an angiogram. I may not, get them cyclophosphamide at the beginning, There are patients who have a possible CNS vasculitis, not really true CNS vasculitis for sure or definite. I may or may not use cyclophosphamide. This has to be individualized. We are currently trying to, the whole idea of this consortium that we are having is, and the multi-institutional effort is to try to come up with some criteria to better diagnose this, and as well as some guidelines to how to treat these patients. And we are actually, our hope is to better classify these patients under definite, possible, or probable with the diagnosis that give you a better guideline on how to treat these patients. So at this point, I will come to this question and I say, depending on the certainty of your diagnosis and as well as the patient himself, whether they can take cyclophosphamide or not. If you're not sure and your patient is really young, but you're not sure if this is atherosclerosis, because sometimes the enhancement in the vessel can be secondary to atherosclerosis, and you're not sure at this point, you're going to give them a trial of steroids, look at their follow-up MRA and see if it gets better or not. At this point, I will not use cyclophosphamide at the beginning.
Okay, last question. First of all, when you use cyclophosphamide, it's oral, correct? 2 milligrams per kilogram per day?
I prefer that, but some patients, remember, these are patients who have strokes.
Yes.
And the oral daily cyclophosphamide, you're going to give it to them every day. In the morning, you're going to ask your patient to empty their bladder very frequently all day and drink a lot of fluid. So some patients cannot do that. So that's the ultimate diagnosis. Your daily oral cyclophosphamide, as we all know, it's our best immunosuppressive medication because you get more cyclophosphamide than the IV. But some patients get IV cyclophosphamide if they cannot do it oral. And I do it for 6 months.
And then after that, you automatically switch to mycophenolate?
Yeah, mycophenolate or Imuran. We'll be using more mycophenolate.
I see. Are there any other questions?
Mycophenolate, I would probably aim to 3 grams if possible, depending on the tolerance and the weight of the patient as well as the white count.
Okay. I think that's it. Thank you so much, Dr. Hajali. Thank you so much for coming and talking to us. It was a great talk.
Thank you for inviting us.